exciting webinar. When I first got the invitation to give this presentation, I have to admit that my initial reaction was, induction? What is there to talk about in induction? Well, 75 slides later, I was panicked how I will tell you about all the cool things that are happening with induction in just 25 minutes. So hold on to your seats, folks, as we embark on this updated induction journey together. Looking at the timeline of immunosuppressive therapies, you can see the source of my initial apprehension. For the last 25 years, we literally had no change in our induction armamentarium. If anything, we lost agents like OKT3 and daclizumab. Moreover, if you look at our pipeline, the focus is very much on antibody reduction, complement inhibition, and co-stimulation. Our SRTR data trends tell a similar story. Over the last 10 years, we see little change in the induction regimens used across all organs. However, what has changed is that our annual reports are becoming less and less detailed about induction strategies that we're using. For those of you that were around long enough to remember, SRTR would offer granular information about the use of individual agents before 2011. For example, on this slide, you can see the breakdown of each induction agent used in 2010. Nowadays, reports are simply dichotomized to depleting and non-depleting approach, and after 2018, in liver and intestinal transplantation, the report simply states induction therapy used, yes or no. This slide offers a summary of the three most widely used induction agents, thymoglobulin, basiliximab, and alemtuzumab, highlighting their individual characteristics. I think that most of us would agree with the recommendation and established truths that I have listed here in the last two columns of this slide. In our patients that are at high risk for rejection, graft outcomes are improved with the use of depleting agents, but this benefit comes with a price since they are associated with more complications such as infections and malignancy. The risk-benefit analysis of low-risk patient population indicates that basiliximab may be the preferred agent in this population. When discussing induction, the source we cite most when describing these characteristics tends to be the first head-to-head clinical trial that compared these agents in low and high rejection risk population, namely the Hanaway randomized control trial that I cited here as a reference for you. One question that Hanaway did not answer is if induction therapy choice impacts appearance of DSA in our patients. For this answer, we can look at a study by Bath and colleagues that compared outcomes of low rejection risk patients undergoing kidney transplantation using 3 different induction regimens. All patients were considered to be at low rejection risk with low PRA and no DSA at baseline. Standard of care approach included 1 or 2 doses of basiliximab along with triple immunosuppression regimen. Patients that were younger, so less than 60, with diabetes or with steroid sensitivity, were given alemtuzumab along with tacrolimus, mycophenolate, and early steroid withdrawal. Thymoglobulin was used in patients with end-stage kidney disease due to autoimmune disorders with a risk of recurrence, such as IgA nephropathy or FSGS, in which case maintenance with triple immunosuppression was also used. Looking at the outcomes at 12 months post-transplant, we see that alemtuzumab cohort developed more de novo DSA, while other outcomes remain comparable. Please keep in mind that alemtuzumab cohort was considerably different, as highlighted on this slide. This cohort, interestingly, had more belatacept-treated patients. Most likely, patients were converted to belatacept with the appearance or emergence of DSA in steroid-free setting. Due to the retrospective nature of this study, no real conclusion can be drawn about induction and DSA. However, this remains, to my knowledge, the only study that examined this phenomenon. So this brings us to the age-old question: who gets antibody induction at your center? Typically, to answer this very much nuanced question, we will examine patient-specific risk factors, for example, presence of donor-specific antibodies and ethnicity, organ-specific risk factors such as inherent immunogenicity of the transplanted organ or risk for ischemia or reperfusion injury. And finally, center-specific risk factors, for example, are you using steroid avoidance or are you introducing other experimental methodology that may increase rejection risk in your patient? However, although for the most part, we all evaluate same general characteristics when considering antibody induction choice, Centers around US will often select completely different approaches when presented with the same patient and organ details. As we all know, this makes transplant research difficult and interpretation of our research data an incredibly challenging task. So I want to take a moment and try to answer, is there a better way to stratify rejection risk in our patients? And subsequently, we will also take a closer look at ischemia reperfusion injury as a potentially modifiable risk and therapeutic approaches that are used and currently available to mitigate that risk. So let's begin by looking at an often overlooked patient-specific risk factor, and that is HLA matching between donor and recipient. I think every single transplant pharmacist is familiar with these images that tell a story of patient outcomes stratified by degree of ABDR HLA mismatch. The higher the degree of mismatch, the more rejection risk you carry and lower your long-term survival will be. Please note that in terms of population represented in this slide, we're looking at outcomes of living donor kidney transplants where donor was a sibling, so an absolute ideal transplant match. As a seasoned transplant educator, I have now taught generations of pharmacists and physician learners that this disparity really mattered at infancy of transplantation, but that now that we have powerful modern medications, the degree of mismatch is less relevant. And I'm sure many of you have also done the same thing. However, when we look at our current trends, these lines continue to pull apart even when analyzing the most recent kidney transplant data from the modern era of transplantation. Yet the number of highly mismatched transplant continues to be the norm in the United States, as seen here on the right side of the slide. The question that we will examine today is if the new tissue typing technology can help us redefine rejection risk based on donor-recipient HLA matching, and if this information can eventually be used to guide immunosuppression selection. The traditional ABDR HLA tissue typing is based on simple serologic examination of HLA phenotype present on our cells. This is considered a low rejection tissue typing screen. The high-resolution molecular tissue typing technology that is used today is DNA-based and can describe in full detail complete HLA protein sequence. You may have noticed that over the last decade, HLA reporting has changed considerably, with significantly more HLA detail being presented for each antigen in the tissue typing report. In terms of significance, the alleles with the same serotype, for example, A11, differs from serotype A12 by only few nucleotides. However, alleles A2 and A23 will have distinguishing genetic sequences and likely significant differences in the final protein structure. When it comes to recognizing non-self antigen or donor antigen, the immune response is directed against surface peptide structures on our HLA, shown here in yellow in this giant big molecule. The T cell will recognize processed HLA peptides, again separated here in yellow, while the B cells will recognize the entire protein structure of the HLA using their B cell receptor. The HLA epitopes that can trigger a B cell immune response are called eplets. So eplets are functional regions of an HLA molecule that can be recognized by B cell, leading to its activation. When looking at high-resolution HLA tissue typing compatibility, we are examining differences between donor and recipient HLA by defining the degree of eplet mismatch between their HLA molecules. Let's look at one example below. Here we see 5 different HLA antigens, excuse me, A1, 2, 3, 11, and 80. We can see that the degree of eplet mismatch is highest between A1 and A2 antigens, while the degree of eplet mismatch is the smallest between HLA A1 and A80, with only 11 points of difference, making it a better or more suitable match to A1. Do not be confused by the nomenclature of HLA. HLA are numbered according to the sequence of their discovery, so they can only inform about the frequency of HLA in our population and not about the structure or function of the molecule itself. If we now look at our next example, we can see that HLA A3 and HLA 11 have the smallest degree of eplet mismatch, making them a better match. So are you wondering, where are we going with this? How can we use this information clinically? Well, today we have 3 molecular mismatch assessment approaches that have been developed over the last 15 years or so. And I have them listed here for you: HLA-EMA, Pilch, and HLA Matchmaker. Retrospectively, all 3 approaches have been used to show a clear and independent association between the degree of HLA mismatch and the development of de novo DSA, occurrence of rejection, and graft loss across different organs. At this time, most data comes from European, predominantly Caucasian population. However, more recently, molecular compatibility has been examined in a more diverse population cohort and could possibly lead to explaining the observed differences in outcomes between our ethnically different populations. Please be advised that what I presented today is a very limited view of the science. However, I believe that as transplant clinicians, it's important to understand how availability of this new technology may impact our patients' outcomes, but also our jobs in future. Using molecular tissue compatibility algorithms, pharmacists can be asked to participate in selection of an induction and maintenance immunosuppression regimen that is specifically tailored for their patient based on the new rejection risk stratification approach. And if any of you are already doing it, I would love to hear more about your experience. Now let's shift gears and talk about ischemia reperfusion injury. Another report that is traditionally published by SRTR describes rejection outcomes based on induction agent used. For those of you that stalk SRTR reports as I do, you may have noticed a new trend emerge after 2020, and that is the use of dual induction with lymphocyte depleting and non-depleting agents together. Explanation behind this trend for most of you will be obvious, and that is following kidney allocation system change in 2021, we see more low rejection risk patients converted from non-depleting induction to depleting induction in setting of IRI that develops into ATN, that develops into DGF, that is established and manifests in the post-transplant period. If you ever question this practice, you're probably right. We currently have 2 reports available that examine outcomes of patients using dual induction. Please note that they both come from the same research group. The first, smaller report focused on Canadian cohort of patients of about 430 kidney transplant recipients, where dual induction was used in 10% of the population. Those receiving dual induction had worse allograft function, increased risk of all-cause graft failure, and death-censored graft failure. The second report examined U.S. population and found that dual induction was used in 5% of patients. Typically, patients that received dual induction were Black, had high PRA exceeding 80%, on steroid-free maintenance with long cold ischemia time and delayed graft function. As with previous study, all-cause and death-censored graft failure rates were higher in the dual cohort, and in this population, 5-year risk of death was also higher compared to the thymoglobulin alone treated patients. Administration of lymphocyte depletion prior to allograft reperfusion has been associated with less DGF. Several studies have shown that acute rejection and DGF have additive impacts on long-term outcomes. This is no new fresh info. Even if you believe that thymoglobulin might not directly prevent DGF, the impact may be minimized by its ability to reduce the incidence of acute rejection in this population, but this benefit may need to be carefully balanced with the risk of infectious complications and malignancy. I would like to share with you a study that compared outcomes of 3 induction agents in donors after cardiac death, a risk factor that is often associated with ischemia reperfusion and DGF. The study was a spin-off from 3C trial. Some of you may remember the 3C examined basiliximab versus alemtuzumab induction with mycophenolate, tacrolimus, and prednisone. The study patients were compared to thymoglobulin-treated cohort at a single center that participated in the trial. At baseline, the thymoglobulin group had some notable differences, and namely the degree of HLA mismatch, particularly in the DR antigen. In terms of outcomes, delayed graft functions was numerically higher in the thymoglobulin cohort, but this difference was not significant. What was significant was that the acute rejection rate was lower in the thymoglobulin group. However, ultimately, this does not translate into additional benefit in terms of graft and patient survival in long and short term. At this point, the impact of available induction agents in prevention and treatment of ischemia reperfusion injury remains unclear. With increasing use of organs at risk for ischemia reperfusion injury, questions arises if we should consider using adjunctive therapies in setting of induction regimen. To better understand which therapeutic approach may best be suited as an adjunct induction agent, we need to better understand immunopathology during IRI. During transplantation, ischemia reperfusion injury occurs when blood supply is suddenly restored to the oxygen-deprived donor tissue after a period of interrupted perfusion. Distress cells lyse, releasing endogenous damage-associated molecular patterns, or DAMPs, that act as danger signals for our innate immune system. DAMPs have uncanny ability to activate complement system that ultimately produces inflammation and more cell lysis. Membrane attack complex, or MAC, is the terminal step of complement activation cascade that ensues. Assembly of MAC leads to generation of pores in the surface of affected cells that disrupt the integrity of cell membrane, leading to cell lysis and death. During this process, the cleavage of complement components C3 and C5 results in generation of often overlooked immunologically active remnants C3a and C5a, pictured as pink and blue triangles here. Once released, these complement remnants promote inflammatory cell recruitment, specifically macrophages and neutrophils. These cells release pro-inflammatory cytokines and produce reactive oxygen species, as seen here in the blue box. The ultimate consequence is more intense inflammatory immune response, further cell apoptosis, and additional tissue necrosis. It's important to understand that while the ultimate consequence of complement activation is generation of MAC and cell lysis, the immunologically active remnants contribute to inflammation and can enhance ongoing adaptive immune responses. As the progressive tissue damage remodeling continues, allograft endothelial cells upregulate expression of MHC class 1 and 2 proteins on their surface, segueing into adaptive immunity activation and increasing rejection risk of the allograft. Fortunately for us, activation of the complement system is highly regulated both physiologically and more recently pharmacologically. Many agents, as you can see here, are currently available, and I included them for your review as along with their therapeutic targets. Several have been or currently are explored in prevention of ischemia reperfusion injury and transplantation. Although terminal complement activation seems an appealing target, we have to keep in mind those immunologically active remnants. So C5 blockade actually might be the least appealing options. Inhibition of complement activity at the level of complement components C1 or C2 will prevent generation of C3 and C5 byproducts, potentially leading to less inflammation and tissue injury. Although published data on use of complement inhibitors is still relatively small, we can anticipate more research will be generated in this field over the next 10 years as we explore inhibition beyond C5 and focus on inhibiting complement cascade at an earlier junction, for example, with C2 and C1 blockers. Will complement inhibitors find their place as adjunct therapies for our currently available induction agents is still very much to be seen. Okay, guys, I promise that in this section, I will not mention immunology at all. Instead, let's focus our attention on various induction stewardship approaches. As clinical pharmacists, we are tasked with a difficult job of balancing patient outcomes with costs of therapy. And as we all know, transplant therapies are expensive. As our health system moves away from traditional reimbursement models and we transition into value-based reimbursement models, transplant pharmacists are ideally suited to demonstrate our value through cost savings while maintaining efficacy and safety standards for our patients. Recently, Dr. Jorgensen and colleagues published an excellent summary of induction stewardship initiatives and literature that supports these practices. This paper can serve as a call to action for all transplant pharmacists to make impactful change in your induction protocols. However, it also highlights the paucity of data on which we base decisions about induction strategies we now almost take for granted. Strategies discussed in the Jorgensen article are induction agent specific. I augmented this paper information on this slide to include the total number of patients where the stewardship approach was documented in a peer-reviewed publication form. So, for example, 2 studies describe the abbreviated single-dose basiliximab approach with number of patients from both studies totaling 200. Although approach to shift the second dose of basiliximab to the outpatient setting has been common habit at many institutions, we currently have 0 published data on this practice. I'm looking at you, UIC team. In this context, this paper really highlights the importance of compiling your data and publishing your stewardship success stories. Moving on to alemtuzumab, for those of you that can get your hands on this medication through limited distribution program that is still active, by the way, the proposed alemtuzumab stewardship options are primarily based on Hanaway trial, with one exception that I added here for you. This is our own internal UIC study where we substituted alemtuzumab for thymoglobulin in African-American cohort with no additional rejection risk factors. The last column describes thymoglobulin initiatives, with dosing based on ideal body weight being the most published, and at the time of obesity pandemic, most relevant cost-saving strategy. Another important approach described is eliminating need for central line placement for thymoglobulin administration and shortening induction regimen by combining doses to limit hospital length of stay. One interesting stewardship strategy includes risk stratification of thymoglobulin dosing, or ThymoLight. This approach benefits low rejection risk patients where thymoglobulin is used as an agent of choice anyway, by exposing them to less overall thymoglobulin. In these studies, patients are dosed below the recommended 6 milligram per kilogram dose, but how low is too low? Since publication of Jorgensen paper, 2 studies describe this risk stratification approach. In 2018, Singh and colleagues showed that using low cumulative doses of 3 to 4 milligrams per kilogram in their non-sensitized patients resulted in low rejection rates at 1 year with no difference in their major outcomes. Patients were maintained on triple immunosuppression maintenance regimen. I think this is key. They also reported over $1 million in savings and shortened length of stay after converting to this approach. Mehta and colleagues published their experience with 543 patients using low-dose thymoglobulin, so less than 5 mg per kg, in a less sensitized cohort. In this case, using less thymoglobulin made a significant impact in rejection outcomes with no difference in infections. According to Mehta, T-cell mediated rejection was present in 34% of patients in low thymoglobulin dose group versus 22% patients in regular dose group. Use of low-dose thymoglobulin in this study was associated with twice the odds for developing early rejection. The rejection risk increased with further dose decline. Of note, these patients were maintained on steroid-free tacrolimus mycophenolate regimen. Mehta concluded that low doses of thymoglobulin are not safe with high rejection rates and otherwise a low rejection risk cohort. Finally, I leave you with a recent meta-analysis that examined the data from 23 cohort studies and 3 randomized control trials totaling to about 3,500 kidney transplant recipients. All of these patients were maintained, most of these patients were maintained on corticosteroids, and you can see different approaches to thymoglobulin. The authors concluded that thymoglobulin induction doses between 3 and 4.5 milligrams per kilogram are as effective as higher doses while minimizing potential adverse effects in kidney transplant recipients. And in this last section, I would like to introduce you to a new induction agent. Our current depleting agents produce lymphocyte depletion through these 4 distinct mechanisms that I've listed here. The problem is that the current induction agents, most memory lymphocytes are able to actually evade the destruction by them. So we have this discord in population that's preserved with T memory cells being majority of that lymphocyte population that's remaining. So let's meet Ciplizumab. This is a new adhesion molecule blocker that can deplete T cells, including memory lymphocytes and natural killer cells. Ciplizumab targets CD2 protein on the surface of T cell. The normal function of adhesion molecules like CD2 is to help stabilize immunologic synapse, allowing naive T cells to respond to signal 1 and 2 better, ultimately resulting in T cell activation. Naive T cells typically express low levels of CD2. Its expression is significantly upregulated when cells are activated. Memory T cells are phenotypically different. They constitutively express high level of adhesion molecules that allow them to respond quicker to an antigen. With Ciplizumab, T cell depletion was observed at higher doses, while energy was achieved at lower doses. And for this reason, this energy-inducing ability, Ciplizumab was first studied in tolerance induction, so probably why we didn't hear so much about it. More recently, This agent, this induction agent, is being trialed in a larger multi-center study of kidney transplant patients, comparing the regimen of siplizumab, belatacept, mycophenolate, and prednisone to the standard of care listed here. It is also being studied in autoimmune liver disease and liver transplantation. So with this, I leave you and take my bow. Please share any comments or feedback or questions to this email. Thank you all that tuned in.
All right. Hi, everyone. My name is Krysta Walter, and I'm going to be following Dr. Campara, focusing on the same topic of novel induction immunosuppression strategies, but pivoting a little bit to the cardiothoracic transplant population specifically. I have no relevant conflicts of interest to disclose, but I do want to note that I will be discussing the off-label use of several of our available anti-induction therapies throughout this presentation. So in terms of objectives today, I'm going to be focusing on the latter two objectives for this presentation, as Dr. Campara thoroughly covered the first objective nicely. So first, we'll be reviewing modern induction strategies and agents in the heart and lung transplant population specifically, and then we'll look at novel ways to use available agents in this population. So again, looking at the history of induction immunosuppression, we really don't have any new agents to talk about today. Of course, we have our steroids that came to the market in 1957, followed several years later by the introduction of our antibody depleting therapy. In the late 90s, our IL-2 receptor antagonist came about, and then our last induction agent, alemtuzumab, came about in 2001. Unfortunately, several of our available agents have been voluntarily withdrawn from the market, or have limited access at this time. So this brings us to 2024. Where are we now? In the heart and lung transplant population, we really only have 3 available antibody induction agents available in our repertoire to use. So for the most of this presentation, I'll be focusing on how we've been utilizing these agents in the modern day and age. Looking at overall induction agent use in the lung transplant population, this is SRTR data from the 2022 annual report. And you can see in the adult lung transplant population, most of the patients are receiving some form of induction therapy, and use has increased over time. Similar trends have been seen in the pediatric lung transplant population as well, where the majority of patients are receiving some form of induction therapy. Looking at international trends through 2017, not only has use of induction increased in the adult lung transplant population, but specifically use of our IL-2 receptor antagonists have largely increased over time. In the pediatric lung transplant population, we've seen similar trends where most of the induction agents used are the IL-2 receptor antagonists. However, we have seen a recent increase in the use of our polyclonal antibody depleting therapies as well. Now, looking at whether or not induction actually impacts outcomes in the adult lung transplant population, this was a registry analysis done in 2022 of the UNOS database that really looked at overall induction regimens in the adult lung transplant population. And this registry analysis did conclude that use of induction overall decreased long-term mortality compared to no induction. And this was significant whether or not basiliximab, alemtuzumab, or ATG was utilized. In this analysis, they also did a propensity matched analysis of those who received basiliximab induction compared to no induction therapy. And they found that overall basiliximab was associated with a decrease in overall and 90-day mortality, a significant decrease in treated rejection, as well as renal failure after discharge that did translate into a significant reduction in length of stay. There were, however, no difference in outcomes in terms of chronic rejection, infection, or malignancy between use of basiliximab and no induction. In this analysis, they also did a nice cost-effective analysis looking at whether or not basiliximab was a cost-effective strategy. And they did indeed see that basiliximab translated into a net cost savings of around $2,800 per patient compared to no induction, leaving a cost-effectiveness ratio of around $3,700 per life year gained, which was well below the a priori set threshold of $61,500. Flipping gears to the heart transplant population, we see much different induction strategies in this population compared to the lung transplant. You can see in the adult side, there's about a 50-50 split of whether or not patients are receiving induction therapy for heart transplant. In the pediatric heart transplant world, there is a little bit more use of induction therapy that's been consistent over the past few years, with most pediatric heart transplant recipients receiving induction. When looking at what agent is used, again, this is from an international database. On the adult side, this is data through 2017. IL-2 receptor antagonists were primarily used, but ATG was also used in a subset of patients. And then on the pediatric side, there was a little bit more use of our polyclonal antibodies, followed by a minority of patients receiving IL-2 receptor antagonists. Now, one thing that's really important to know about the adult heart allocation, the adult heart induction practices is that in 2018, the adult heart allocation system actually changed from a 3-tiered system to a 6-tiered system, with the goal of really prioritizing those at the highest risk of mortality. This did inadvertently actually shift our induction practices. So this was a UNOS registry analysis looking at adult heart transplant recipients who had received some form of induction therapy, and they compared patients who were transplanted in the old heart allocation system compared to those who were transplanted in the new allocation system. Overall, what they found is there is a trend towards decreased induction in the new allocation system. And if induction was used, thymoglobulin was more commonly used in the new allocation system compared to the old. Looking at the patient profile of those who were transplanted, in the new allocation system era, there were sicker patients. So there were more patients that were in the intensive care unit on ECMO, ventilator, or temporary intra-aortic balloon support at the time of transplant, and a significant decrease in the amount of those using LVADs as a bridge to transplantation. When they looked at outcomes of those who received thymoglobulin versus basiliximab in both the old and new heart transplant allocation era, thymoglobulin in both of these eras was associated with significant reduction in both rejection as well as an infection, but this did not translate into a significant decrease in overall mortality. Again, looking at those who were transplanted in the new heart transplant allocation era, they found a significant decrease in the amount of hospitalization for infection and a large decrease in drug-treated rejection in the first year. And again, no difference in overall mortality. So really, this suggests that those receiving thymoglobulin induction in the new era had a largely lower risk of acute rejection in the first year. So as can be seen with the 2018 heart allocation system change, there's a lot of different factors that can impact our induction practice. So there are several external factors that are out of our control, such as things like allocation systems changing, as well as center-specific trends, such as what maintenance immunosuppression strategy is used or specific internal data. Additionally, agent availability, as I alluded to earlier, is a large factor that often impacts what induction therapy we are able to utilize. And then, of course, taking into account both our donor and recipient rejection and infection risk profiles. So for the next portion of the presentation, I'm really going to be focusing on our old drugs or our standard induction agents that have been used in this population and how we've been utilizing them in novel ways in the modern day and age. So I do want to refocus us on the purpose of induction therapy overall. Of course, it is to prevent acute rejection in certain patients. In the heart and lung transplant population specifically, acute rejection is a known risk factor for chronic rejection development, which impacts overall survival. However, not all of our cardiothoracic transplant recipients may need induction therapy for the sole purpose of acute rejection. In these patients, it may be more so to minimize or delay the initiation of maintenance immunosuppression in effort to prevent toxicity that can contribute to worse outcomes. Notably, after heart and lung transplant, postoperative renal dysfunction, and subsequent need for renal replacement therapy is a large predictor of overall survival. So one of the strategies that's been published initially first in the adult heart transplant literature, but more recently in the lung transplant literature, is using induction therapy for a renal sparing indication rather than an immunologic indication. So this was a retrospective review of 236 bilateral lung transplant recipients who received either induction therapy or no induction therapy. Those that did receive induction therapy received it because they were considered high risk for postoperative renal dysfunction, as defined by their history of chronic renal disease, their creatinine or eGFR at the time of transplant, or if they were on a ventilator or ECMO support preoperatively. In the induction group, they received basiliximab on post-op day 0 and 4, and the main difference between the no induction group was that they didn't actually have tacrolimus initiated until post-operative day 7. In the no induction group, they then categorized the patients as to whether or not they would still fall into the high risk for postoperative renal dysfunction group, but did not receive induction, and then those who were not considered high risk for postoperative renal dysfunction. Their primary endpoint was looking at postoperative acute kidney injury, which was defined by a change in their serum creatinine from baseline, a decrease in urine output, or need for renal replacement therapy post-transplant. When looking at their overall outcomes, those who received induction therapy with delayed CNI initiation had a significantly reduced rate of acute kidney injury. It was almost half that of those who were considered high risk for renal dysfunction and did not receive induction therapy, and actually lower than those who were considered low risk for postoperative renal dysfunction to begin with. This, in terms of acute rejection outcomes, they found no significant difference in acute rejection, and this was despite their time to therapeutic tacrolimus level being over 3 times greater in the high-risk induction group compared to the no induction group. Interestingly, they did see a significant decrease in infections in the induction group overall, but there was no difference in other complications as well as short-term surgical mortality. So overall, in this small cohort, basiliximab induction with delayed CNI initiation in patients who are at risk of postoperative renal dysfunction did decrease postoperative acute kidney injury without increasing the risk of short-term acute rejection. Another study that was looking at basiliximab looked at, can we give less drug overall and achieve similar outcomes? And so this was actually a prospective study looking at 17 adult heart transplant recipients where they used a much smaller dose of basiliximab rather than our standard dose of 20 milligrams. All patients received 10 milligrams on post-op day 0 and 4, followed by maintenance immunosuppression with a calcineurin inhibitor, mycophenolate, and corticosteroids. Again, this was a very small cohort of only 17 patients. It was also a very low immunologic risk cohort with only 2 patients having a class 1 or 2 PRA of greater than 10%. Interestingly, most of these patients were started on cyclosporin after transplant, which is likely reflective of the country that this study was done in. And these patients did have delayed CNI initiation as well, and the time to therapeutic CNI level was 14 days. Looking at overall efficacy and safety in this study, they found only 1 patient did not survive through month 12, and there were 2 patients who had an episode of 2R or higher acute rejection, both which occurred by the first month post-transplant. One was in a patient with a subtherapeutic calcineurin inhibitor level, and the other was in a patient with a class 2 PRA greater than 10% at the time of transplant. Overall, the investigators concluded that this practice resulted in favorable efficacy and safety outcomes in their patient population. However, this study is really limited by the fact that they don't have any control arm. One of the mechanisms that the authors looked at was that with just a dose of 10 milligrams of basiliximab on post-op day 0 and 4, you do actually achieve adequate CD25 suppression. However, you just achieve it for a shorter duration. So you can see here that with the 20 milligram dose, the duration was significantly shorter at 20 days compared to 37 days. Another less is more induction strategy that's been looked at in the abdominal transplant population previously, and also in the heart transplant population, is can we give less thymoglobulin and achieve similar outcomes? So this was a retrospective study of adult heart transplant patients who were categorized as to whether or not they received their full induction protocol, which was a cumulative ATG dose of 4.5 mg per kg, or partial induction, which was less than 4.5 mg per kg cumulative. Of note, in the group that received partial induction, this was mainly due to intolerance of thymoglobulin, as it was held if patients had platelets less than 75, active infection, hemodynamic instability, or open chest post-transplant. When they looked at their overall cumulative incidence of severe rejection, as shown in the figure on the top left-hand side, there was no significant difference in acute rejection through 22 months post-transplant. But you can see here at around the 5-month post-transplant mark, there was a significant uptick in those in the partial induction group who had acute rejection. This did not translate into an overall difference in survival between the two groups throughout the first 2 years post-transplant. They looked at rates of infection as well, and these were similar between the groups. They also looked at different ATG dosing quartiles and compared the amount of lymphocyte depletion that was achieved with these dosing quartiles, and they found no significant difference in the amount of depletion between baseline and week 4, regardless of how much cumulative thymoglobulin was received. Overall, they found no association with lymphocyte count and acute cellular rejection at 4 weeks as well. Now I'm going to pivot gears here a little bit to some agents that we've seen in transplant use for other indications, such as treatment of rejection, and look at how they've been used as induction strategies in the cardiothoracic transplant population. So the CTOT11 trial was actually looking at and investigating the question of whether rituximab as an induction therapy practice would decrease the incidence of cardiac allograft vasculopathy post-transplant. And so this was actually a multi-center randomized double-blind placebo-controlled trial of adult non-sensitized heart transplant recipients who were randomized to receive rituximab on post-op day 0 and 12 or placebo. All patients did get baseline intravascular ultrasound imaging at baseline and month 12, as their primary outcome was the change in percent atheroma volume from baseline to 1 year. In this study, for their primary endpoint, as shown in figure 3 on the left, they actually saw a surprising finding. They saw significantly higher changes in PAV at month 12 in the rituximab group compared to placebo. When they looked at the change in the MIT between the two groups at baseline and month 12, similarly, they found a larger change in MIT in the rituximab group. There was no difference in overall 6 or 12-month mortality between the groups, and no statistically significant difference in acute cellular rejection or donor-specific antibody development between the two groups, and infection rates were comparable. So this was actually a surprising finding to the investigators, as the theory was if you decrease the amount of donor-specific antibodies that develop, you may decrease the amount of cardiac allograft vasculopathy that develops. But overall, the authors concluded that rituximab induction in the non-sensitized adult heart transplant population is associated with significant harm and should be avoided. Similarly, the same concept was studied in the pediatric lung transplant population with the same hypothesis that use of rituximab as part of an induction strategy would theoretically decrease the amount of donor-specific antibody development and subsequent risk for chronic lung allograft dysfunction after transplant. So this was another randomized double-blind placebo-controlled trial that looked at pediatric first lung transplant recipients who were randomized to either rituximab on day 0 and 12 or placebo. You can see here the sample size in this is very, very small, largely due to the fact that this is pediatric lung transplant. And the key distinction from this study and the study I just referenced in the adult heart transplant population was that both of these groups did receive anti-thymocyte globulin induction as part of the study. The primary endpoint was a composite of chronic lung allograft dysfunction, death, or listing for retransplant, And then they also looked at other acute rejection and primary graft dysfunction endpoints as well. And all patients were followed for 1 year post-transplant. So at baseline, the average age was around 13 years old, and most of the patients were Caucasian. The amount of patients with an HLA mismatch of 3 or above was the majority of patients, and there were slightly more patients in the rituximab arm at baseline that had pre-existing donor-specific antibodies. When looking at the results of this study, their primary endpoint is here on the figure on the left, which was their composite endpoint of freedom from chronic lung allograft dysfunction, death, or need for retransplant. There was no significant difference between rituximab and placebo in their primary endpoint. However, remember, this study was significantly underpowered due to low enrollment, and it did somewhat favor the rituximab group in their trends. When they looked at the amount of patients that were positive for DSA post-transplant, overall, there's a significant reduction in those who were positive for DSA post-transplant, as well as a significant reduction in those who developed de novo DSA with the rituximab group compared to placebo. They also did a nice B-cell analysis, which did show that this dosing regimen of rituximab achieved adequate B-cell depletion by 4 to 6 weeks post-transplant, and these B-cells did repopulate by month 18 post-transplant. Looking at their other outcomes, they found no difference in the amount of primary graft dysfunction or acute cellular rejection between the two arms. There were no cases of antibody-mediated rejection in the rituximab group, while there were 2 in the placebo group. And overall, in both of these groups, there was a high rate of adverse events related to study drug and a lot of adverse events related to infection. Most of these infections were viral in nature. However, they were similar in terms of incidences between the 2 cohorts. So overall, this study did demonstrate that addition of rituximab to an antithymocyte globulin induction regimen in pediatric lung transplant was associated with a significantly reduced incidence of DSA development without increasing side effects. And finally, I'm going to be talking about somewhat of a novel concept in the cardiothoracic transplant literature, looking at use of IL-6 inhibition as part of an induction practice. So interleukin-6 is a pro-inflammatory cytokine that we know plays a role in B-cell maturation as well as antibody formation. It also directs cytotoxic T-cell differentiation, and it does inhibit regulatory T-cell development, which we know are associated with tolerance of the graft. And so what I'm going to present to you here today is actually looking at animal models. So these are mice that received a cardiac transplant. And in this animal model, what they looked at is an induction regimen of ATG in combination with 3 doses of an IL-6 inhibitor, followed by a maintenance immunosuppressive regimen of CTLA-4 immunoglobulin, which is essentially an immunoglobulin that's focused on co-stimulation blockade, so similar to our co-stimulation blocker belatacept. And then they followed these mice that were transplanted throughout 100 days. What they found interestingly was that the mice that survived the longest were those that received the combination of ATG and IL-6 inhibition as part of an induction strategy. The group that survived the second best was those that received ATG induction alone, followed by their maintenance immunosuppression with the co-stimulation blocker. And then all the other groups did not survive as well. Namely, those who received just IL-6 inhibition alone did not fare well, or those that received no induction strategy at all did not fare well. When they looked at the percent of patients that were DSA positive, they found that overall, those who received the combination of ATG and IL-6 inhibition had significantly less DSAs developed post-transplant. They also found less severe grading of cardiac rejection in the mice that received the combination induction therapy group. Interestingly, they also looked at the amount of regulatory T cells that were actually within the cardiac graft, and they found that compared to ATG induction alone, ATG induction plus IL-6 inhibition was associated with a significant increase in the amount of regulatory T cells within the graft, which are thought to promote tolerance. So the mechanism for this is that IL-6 inhibition allowed for decreased inflammation. It also allowed regulatory T cells to accumulate in the cardiac allografts. IL-6 inhibition has also been associated with an increase in regulatory T cells as well, and this overall prevented acute rejection. So unfortunately, I don't have any available clinical data to present looking at the use of IL-6 inhibition as part of an induction strategy in non-sensitized cardiothoracic transplant recipients. There is some information looking at desensitization therapy, but I'm not going to go into that today for the purposes of this talk. And I did want to just bring everyone's attention to an ongoing clinical trial looking at tocilizumab in cardiac transplantation. In this trial, tocilizumab will be started at the time of transplant and considered as part and continued as part of their maintenance immunosuppression therapy as well. So in summary, the preferred induction strategy in modern cardiothoracic transplant in a broad patient population is really not well defined at this time, but you can see here that induction strategies are constantly evolving based on both internal and external factors. I do think it's important to tailor the induction strategies based on the overall goal or purpose of induction, and to remember if we're using it for an immunologic or non-immunologic cause, such as to prevent postoperative complications. Some future areas for research include incorporating agents targeting pro-inflammatory markers to our standard induction agents, as we saw in the case of IL-6 inhibition. So thank you very much for the opportunity to talk. And we're happy to answer any questions that you guys have.
We're also happy to entertain questions by email. So please feel free. Krysta, I'm curious in the induction, like coming up with novel induction approaches, has complement blockade been explored in cardiothoracics at all or no?
I did not see it in my literature search. There was actually the most novel things that I actually saw look in the lung transplant literature was actually a lot of looking at different types of like cellular therapies that could be used as part like within the graft as part of ex vivo lung perfusion, like regulatory T cells or mesenchymal stromal cells, but I did not see anything about complement inhibition in that literature.
Cool. Yeah. All right. Well, thank you everyone for your attention. I think our time is up.
Thank you very much, Maya and Krysta, for wonderful presentations. We will give everyone a break. If you could be back to your computers by 11:10, we will get started on session 2 at 11:10.
Welcome back. My name is Stephanie, and I am going to introduce our next speakers for our session 2. Today we have Dr. Abbie Leino. She is a clinician scientist at the Cincinnati Children's Hospital, and her goal is to improve the way we use medications in transplantation through the application of innovative therapeutic drug monitoring and clinical application of model-informed precision dosing. Following her, we have Dr. Jennifer Byrns. Dr. Byrns is a clinical abdominal transplant pharmacist practicing in the ambulatory setting at Duke University Hospital. She is involved in patient care, education, and research endeavors in the transplant field. She is the current PGY2 solid organ transplant residency program director at Duke. Dr. Byrns is actively involved in the AST transplant pharmacy community of practice as a member at large, ACCP Transplant PRN, and an officer of the NC Transplant Pharmacy Association. Her interests are in immunology, pharmacokinetics, and pharmacodynamics of transplant medications and medication-related outcomes. Please welcome me in welcoming Dr. Abbie Leino.
All right, good morning, everyone. Thank you for joining us. So I am really excited to hop right in here. And so the title is Novel Strategies, and I don't know that I would consider this novel, and I kind of went back and forth on exactly how to frame my talk this morning. So what I decided to do is, because I know there's potentially residents on this call, as well as clinicians that have read some of the, the traditional historic papers, repeatedly. So what I decided to do is give a brief overview of some of the historic literature and then kind of do it like a speed journal club, focusing on articles that have been published in the last year, some of which are published in pharmacology journals, which may not be the top of a transplant pharmacist's list of things to peruse. And so hopefully I can bring at least one new thing to each of you this morning. And you guys, as pharmacists, are no strangers to why we need precision dosing, particularly in transplantation, right? We're always trying to prevent toxicity, maximize our efficacy, and preventing rejection, and just kind of, that seesaw balance that we're always playing with our immunosuppressive drugs. And so to get to a precision dosing, this is kind of my little roadmap. For most of our drugs, for our drugs in transplantation, we kind of take either a one-size-fits-all, a stratified, or a standard therapeutic drug monitoring or TDM approach. So tacrolimus, we do our TDM, where we get just trough concentrations and we adjust them to population level targets or our therapeutic range. For mycophenolate, it might be a one-size-fits-all, or maybe your center stratifies it a little bit by age or weight. And so that's kind of how we currently do things. And we know that probably we can do better than that, but it's hard to do better than that, because to do better than that, we need to do more intensive therapeutic drug monitoring. And so we're kind of here and we're trying to get to precision. And so our first problem is whole blood tacrolimus trough concentrations are not always a reliable marker of exposure. And so as transplant pharmacists, we're always thinking, oh, our trough correlates with AUC, but what does correlate with AUC actually mean? And so if we look, these are some of the early studies that obtained AUCs and then compared them to the trough concentration. And we always, I feel like as transplant pharmacists, we're always like, oh, the correlation is 0.8 or the R squared is 0.8. But if we really look at the data, there's a huge range, right? And some studies, that correlation is only 0.3, which means that the trough concentration doesn't tell us a whole lot about exposure, even on a population level. And the reason for that is typically differences in peak. And so you can see there, these are 2 patients in one of my studies. It was done in a fasting state for both of these patients. Their trough is the same, around 5, but obviously those have very different total exposures. And there's lots more papers that can contribute to this, but these are just the early ones until I got tired of creating a table for you guys. And so again, the peak is probably what's driving these differences. And so this is a new paper that was published in a pharmacology journal that I thought was pretty interesting. Its focus is mostly on tacrolimus, though they have mycophenolate in the title. We're going to focus on tacrolimus, the results for tacrolimus from this paper. And so what they did, European centers, there are a handful of them that actually do AUC monitoring as their standard of care. And so they've been doing it for years, and they're starting to get a large body of literature. So there's been a number of papers published out of these groups in the last couple of years, kind of sharing their clinical experience. So this is, standard of care cohort where they were doing AUCs. There's about 800 patients. So a decent sized transplant cohort. And so here is just plotting their AUCs to their trough concentrations for tacrolimus. And you can see that they get an R-squared value of 0.8. So good, right? Well, when we think about the individual patient, which is what we want with precision dosing, that trough of 5 that they were targeting can correspond to a wide range of actual AUCs or total exposure. So it went from 65 to 155 nanograms per hour per milliliter. So that's a threefold change that you wouldn't know about because you were just looking at trough concentrations. And then they also looked at, okay, was AUC or trough concentration better predict rejections? And so what we see here are some plots that I thought were a nice representation of the data, where you have the probability of rejection on your y-axis, and then either your AUC or your trough concentration on your x-axis. And you can see that in both cases, there's a point where there's an exponential increase in the probability of rejection. And so that's kind of what they use to establish their therapeutic ranges or targets. And you can also kind of see here that the AUC is associated with slightly better probability. And again, this is late. So these were patients who were more than a year post-transplant, looking between 1 and 3 years. So this is late biopsy-proven acute rejection. And the incidence was 3.6. So even with that low incidence of rejection, they were still able to find a difference. Statistically, AUC was better at predicting rejection than C0 was. So then this is just kind of a layout of those patients. So most of our patients had a therapeutic trough and a therapeutic AUC. So again, on a population level, what we do now probably works pretty well. However, there are those patients where their trough concentration is therapeutic and your AUC is not. And whether that is the AUC is low or high is why you need to do an AUC, so you can figure out the difference between that. And again, the AUC better predicts this probability of rejection. So if your AUC was greater than 75, there was only 0.5% incidence of rejection compared to 8% if your AUC was low. And so what this corresponded to was about 30% of these rejections were in patients who had a therapeutic trough concentration. But they may not have been therapeutic with the AUC. And so it's only 15% of patients with a mismatch. But when we think about improving beyond what we already do, which is pretty good with these drugs, those are the 15% of patients where we probably could change. Those are potentially the 15% of patients that end up relisted for a transplant. And so, just because it's a small percentage doesn't mean it's not something that we could consider improving upon. And so identifying that mismatch may be potentially beneficial. And so if we look at those patients who have a therapeutic C0 but a low AUC, obviously we would expect those patients to be at higher risk for rejection. They're likely to have low or flat peaks. And this tends to correspond with low milligram per kilo doses. So, right, you're not getting as large of a bolus when you take your dose, and so your peak's not as high, or potentially non-fasting administration, right? We know food reduces that peak as well. There's one study that looked at these flat peak population, and they found that these patients were at a higher risk of rejection. There's a second study that I swear I've read at some point that also looked at these peak concentrations and looked for a difference in rejection and didn't find it. But I, for whatever reason, was not able to relocate that to share with you today. So again, transplant, we have lots of conflicting evidence, but it makes sense, and there is evidence to support that these patients with low AUCs but therapeutic C0s are at increased risk for rejection. Then the inverse, where you have your therapeutic C0 but a high AUC, those are the patients that are going to be at risk for toxicity. And these patients have those high or prolonged peaks. And they may also have higher metabolic or metabolite to parent AUC ratios, which again, potentially could be associated with toxicity. These tend to be patients who are high milligram per kilo doses, so potentially are CYP3A5 expressors, though not exclusively. And they also tend to have the low concentration to dose ratio in patients who are actually taking their drug. Those patients may have higher peak concentrations. And so there's this paper that looked kind of exclusively at this population to see, does this high dose with adequate troughs actually predict their exposure? Are they having these high peaks that we think they might be? And the answer was yes, they tended to have a little bit higher and a prolonged peak concentration correlated to a higher AUC. So both populations here, you can see at time 0, they had exactly the same trough concentration, but patients who had a high dose of greater than 0.15 milligrams per kilo per dose. So again, that would be corresponding to your 0.3 milligrams per kilo per day that we often see in our expressor population, but again, not exclusively based on genotype. Compared to patients that have lower than that, you can see there's definitely differences in our exposure, except that trough concentration. So we don't know, we're not seeing this difference in our patients to potentially adjust based on it. And this kind of then gets back to another body of literature that I don't have time to talk about today with that CD ratio. And so there are CD ratios in those patients on a high dose with that higher AUC. They do have that lower CD ratio compared to the other population. And we know from other papers that a CD ratio less than 1.05 is associated with higher mortality, graft loss, BK, EGFR decline, and all of that is proposed to be related to the nephrotoxic potential of tacrolimus. And so if we have patients who are on really high doses, this might be a good population to evaluate the AUC in. Maybe they're experiencing other side effects or things like that, so we can help optimize their doses. So how often would we need to get AUC? And so this paper here suggests that we may not have to do it all that often, that the ratio between the C0 and the AUC is pretty stable. And so once we establish that ratio, we could use it to establish an individual level trough concentration target that we could aim for. And so here is basically the high-level summaries of this paper. If you look at that purple line, that's looking at that AUC to C0 ratio over time. The top plot is between 0 and 5 years, and then the bottom extends that timeline out with, albeit a smaller number of patients, to 15 years. And you can see that's a pretty flat line. And so maybe this means this is something we do every year, every 5 years, just to kind of check in, make sure we're still targeting that individual C0 appropriately, but it seems to be pretty stable. So we wouldn't need to do AUC every time we want to get some information about tacrolimus potentially to enhance our monitoring strategies. So our problem number 2 is mycophenolate. Most of us don't do anything with mycophenolate. Trough concentration doesn't correlate with anything. We know that. And so we just ignore it because doing something else is hard, or we only look at it in a select number of patients. But we also know that the entire regimen is important, or at least I believe so. I know some of you out there probably don't believe mycophenolate adds much, but this study from 2004, I think, does tell us having both therapeutic troughs or AUCs for both TAC and mycophenolate, those patients had a much lower risk of rejection. You can definitely see, kind of a dose response here with if, one of them is therapeutic and the other isn't, you're kind of in the middle. If they're both not therapeutic, you have the highest risk of rejection. And so I think this is just a really nice traditional paper that shows our entire regimen probably does matter, and we should be thinking about it, albeit it's a standard small sample size. But that's just the data we have in transplantation. We also know that there's a lot of PK variability. We know that there can be tenfold differences between patients. There's that poor association between C0 and AUC. There is, between patient variability, within patient variability. We've got lots of data on TAC intra-patient variability. Not as much from mycophenolate, but it does exist. We know there's non-stationarity, so your AUC does change. From early post-transplant to about 6 months, there's usually a change in your overall AUC, even if you don't change the dose. There are drug interactions, even though we often don't think about them. There's different absorption profiles. There's double gamma. You have your enterohepatic recycling that creates all these potentially late peaks. that contribute significantly to your AUC. And so monitoring mycophenolate is hard to do, but probably something that we should consider, at least in some patients. It does have an exposure-response relationship. And if you dig into, all of these papers and these randomized controlled trials, looking at this dosing, we could have a whole debate. I could talk for an hour about the literature that's out there. My opinion is there is an exposure-response relationship, probably that target between 30 and 60, or if you're, someone who likes to aim for the middle, 45, I think probably that makes sense. A lot of the work is with cyclosporin, so that's always something to keep in mind. But definitely, I am a believer in this. And if you want to dig into the literature with me, I'm always happy to do that. So here's a new paper that looked at using model-informed precision dosing, which is basically a computer model that takes the multiple concentrations that they obtained to estimate AUC in patients who were mostly on TAC, and they found better rejection-free survival in those patients who underwent precision dosing. So I'm going to dig into a little bit more detail on this one because I think it's important. While it was not a study intended to look at this, they were study patients. They were in 2 different studies. So these patients were monitored a little bit more closely than your average patient. And then again, it's these European centers where some of them use AUC monitoring as standard of care. And so they looked at patients who got it as standard of care versus those who did not have their AUC obtained. AUC was measured using the ISBA, which is a program out of France that actually, if you wanted to use, you could. That uses Bayesian analysis to estimate the AUC. They obtained samples at 20 minutes, 1 hour, and 3 hours. And again, it's a pretty large population of TAC compared to cyclosporin, though not everyone is on TAC. One of the things that I'm not really sure what to make of with this study is it wasn't, some centers did AUC for everybody and some centers did AUC for nobody. It's a mix. So I don't really know for sure why. A lot of the patients who didn't have this done were on mycophenolate sodium, and so maybe that's why. They started on mofetil, got switched to sodium for GI toxicity, and so they don't do it in those patients, and so that's why some don't have it done. But that's just something to keep in mind. There's kind of split between all of the centers, which maybe is beneficial, but I don't really understand how. They don't explain how the decision was made to do this monitoring. So comparing these 2 groups, they're pretty well balanced in regards to things that we would think would affect our outcome, except for cold ischemia time, although clinically I don't know that I really think that extra hour makes a huge deal, but it would bias towards higher rejection in the therapeutic drug monitoring group. Delayed graft function was also higher, potentially related to that longer cold ischemia time, but again, biasing rejection to have higher rates in the therapeutic drug monitoring group. There were a few more study visits in that group as well, which may bias for lower rates of rejection because they were monitored a little bit more closely. But there was more thymoglobulin use in the control group, which would potentially put that group at a lower risk of rejection. But there were really no differences in CNI or steroid exposures. If you pull up their supplemental materials, which is an excellent example of how you should do supplemental materials, you can see there was a statistical difference at 24 months in TAC concentrations, 5.8 versus 6.8. But to me, that's what happens when you target a trough of 6. There was no difference before or after that. And also when we look at outcomes, there's not really anything that happens. There's very few rejections after 24 months, which we would expect. And so again, I don't know that that difference really makes has any impact clinically. So here you can see our survival plots of rejection-free survival. On the left and on the right is the incidence of rejection. And so you can see these curves separate and that the outcomes are better in those who were in the mycophenolate monitoring group. They also did a multivariate analysis, and you can see that mycophenolate monitoring has a significant protective effect when it comes to rejection. The one thing I want to note is most patients had their AUC between week 1 and 3 months. And so you can kind of see I added that 90-day mark onto those plots. And that patients who had rejection before their first AUC, even if they went on to have their AUC monitored, ended up in the control group. And that's 17 patients with rejection. And so that's why those curves split so early. If you had early rejection, you were in the control group. And I've kind of gone back and forth on what I think about that, whether they should have been excluded altogether. And I wanted to have time because they have all of the data. You could reanalyze this, excluding those patients if you want to. The data is all available online. I just didn't have a chance to do that. But I think because you can see the change at that 3-month time point in the trajectory of those curves, to me, that there's still a significant effect, even without those 17 patients who was early. And we could expect that, right? If you have super early rejection, mycophenolate monitoring probably isn't going to help you unless you were using something for the starting dose. So the dose they got before they, right after transplant was better adapted to them. I wouldn't expect this to affect early rejection. And then the other piece here is again related to the 24-month time point. You can see there really isn't a change in the trajectory of those curves, very few additional rejections after that time point. And they also don't really monitor a whole lot of mycophenolate. And you can see that in that additional survival plot that pops in there. After 24 months, they're really not getting AUCs anymore. Comparing tacrolimus versus cyclosporin, just tacrolimus alone, you see the significant difference. Some of the populations, so the low risk for rejection versus high risk for rejection, are not statistically significant for cyclosporin, but again, there was a small number of patients there. So that may be related to sample size. But I think this is some of the better evidence we have for mycophenolate monitoring with tacrolimus. The other issue with a lot of the existing studies is some of the ones that didn't find positive results also didn't dose adjust enough to actually get the patients in the precision dosing arm into the therapeutic range. You can see here that a lot of patients don't start out there and they make their way closer to the therapeutic range. Of note, they have a really long time horizon on this plot, out to 9 years when the study was really only focused on 3 years. But you can still see there are outliers, so there's a potential need to continue monitoring beyond, one set of AUCs, because you may not stay in the therapeutic range or you may not achieve your therapeutic range on your first dose adjustment. Because it was standard of care and those control patients did not have an AUC that, was obtained and then sitting to be analyzed later, really we can only look at dosing. And you see that at a couple of time points that could, precision dosing group actually has lower average doses. So that means we pulled those people who had high exposure, who were at risk for toxicity, we pulled them down. And that was probably a little bit more common than increasing our dose. But you can see they did achieve some differences in the average dose that was used. About 30% of patients at every of these big time points, a dose recommendation was made. And early post-transplant, about 80% of those recommendations were followed, compared to as they get farther out, that percent of recommendations taken decreases a little bit. So there was at least some response to this and dose changes made in response to the estimated AUC. It also doesn't really answer anything related to toxicity. And it was actually the mycophenolate dosing group that had higher rates, but they look at cumulative incidents, including those reported before the first AUC. And so I think that's probably why a lot of these patients got AUCs, is they were having leukopenia or GI adverse effects. And so they got an AUC in response to it. And that's how patients ended up in that group. So it doesn't really answer, can we reduce toxicity? Because it just wasn't designed to do that. All right, so how do we sample this, right? We know trough doesn't correlate. So we need multiple time points. So what should they be? And so I really like a lot of the work that's coming out of Pamela Jacobson's group at the University of Minnesota right now. This is a recent paper by one of her graduate students that they obtained full AUCs. So, over 12 hours they were sampling and then compared the result they got from the trapezoidal method, right? Think back to your PK courses in school. So that's the most accurate way to get AUC. It's not an estimation. It is the AUC pretty much. To some of the limited sampling strategies that are presented in the literature. And what they found here is that accuracy and precision we're not great. You want your numbers to be less than 15, which is those red dotted lines. And so for most of these equations that are out there, they did not achieve that. So you weren't adequately estimating your AUC with the limited sampling strategy. The one thing I'll note here is these are all regression equations, and the Bayesian methods would probably perform better. But the problem that the authors discuss is that because these are early time points, often within the first 4 hours, you're not capturing the enterohepatic recycling, which contributes up to 40% of your AUC. So if you're not capturing that with your levels, your regression equation isn't going to be able to account for it. If you have a good Bayesian model, you may be able to identify covariates that could predict your EHR, but those have not yet been identified, and that's part of what this group is working on doing. So if we could better capture that EHR, get some later time points, we might even be able to better outcomes clinically if we have more accurate EUC estimates. And then 3, our concentration effect relationship, particularly when we're talking about tacrolimus trough concentrations, is relatively poorly defined. Right, so this is a paper that we'll often talk about that looked at 3 large randomized controlled trials and looked at outcomes by trough concentration. And you can see that among the patients who had rejection in the solid black box plots compared to those in the white box plots, their trough concentrations were not significantly different. So there's, that suggests that, well, maybe there's not a great relationship between those 2 things. But there are also papers that say that there is. So. And so is this because trough doesn't correlate with AUC, as we've talked about, or because not everyone has the same need for the same exposure? I think it's probably a little bit of both. And if we could get some pharmacodynamic biomarkers, that would potentially be helpful. And because I don't have that much time, I'm just kind of going to focus very quickly on commercially available ones. I wrote an entire 5-credit CE chapter for, your upcoming certification renewal. So you guys will all hate me for this probably shortly. So you'll get lots of information there. So commercially available products, right? We're all talking about immunosuppression, minimization using donor-derived cell-free DNA, gene expression profiles, and then kind of the new kid on the block is tortenovirus that has only been commercially available in the US for 6 months or so. So this is the one paper that everybody cites when they talk about donor-derived cell-free DNA and tacrolimus dose adjustments. And what they're saying is patients with a trough concentration less than 8 had higher donor-derived cell-free DNA. Okay, but we also look at this and the open circles are less than 30 days. So we also know that donor-derived cell-free DNA does take some time to decline immediately after transplant. In adults, that's somewhere between like 10 and 14 days. So this may be early. And also, if I have a patient who's less than 30 days, whose trough concentration is less than 8, I'm increasing the dose probably regardless of what their donor-derived cell-free DNA is. So I don't really know that this helps me make tacrolimus dose adjustments, establishes that this is a strong relationship for me. And again, it's also ignoring mycophenolate. It's ignoring total exposure of tacrolimus. This paper here, they call it an observational study. I think it's more of a case series. It looks at 17 patients who are on average 5 years post-transplant and still on 2 grams of mycophenolate after kidney transplant. And then they use donor-derived cell-free DNA with a less than 1% threshold to decide if they can empirically reduce their mycophenolate. Well, I'm pretty sure I would empirically reduce their mycophenolate without donor-derived cell-free DNA in patients who are 5 years out and still on 2 grams. Please don't use this paper as evidence to use donor-derived cell-free DNA. There wasn't even anything in the paper that I could take out for an image for you. So I'm just bringing it to your attention because you may not have seen it, but it's not a great paper. I'm not sure it convinces me of anything related to adjusting my immunosuppression using donor-derived cell-free DNA. I think there are lots of potential biomarkers that are out there. We can continue to work on this and find something that'll work. It'll likely need to be a combination of things, drug specific and general. So that way we can know what drug and how much we should adjust it to optimize the immune response. But we are not there yet. So I think enhanced therapeutic drug monitoring is something we should be aiming for. Additional samples to allow us to estimate AUC using model-informed precision dosing, and potentially in the future incorporating pharmacodynamic biomarkers. This is a quote from 2005, and I don't think much has changed since then. So we use our trough because it's easy. Doing more is hard. And so we just don't do it. And so we need, if we want to do it, we need new tools. And this is where a lot of my work focuses. Home-based sample collection, model-informed precision dosing equals what I am calling enhanced therapeutic drug monitoring. There's lots of tools that we can use to have patients sample at home, which it makes it easier for them, easier on the clinic, allows us to get those later time points to capture mycophenolate intrahepatic recycling. And then there's lots of developing literature around model-informed precision dosing, moving beyond our classic PK models, all the way to systems pharmacology, where we really get all of those immune biomarkers, drug exposure, and put it all together to help us decide what our dose should be. Here's a handful of papers. Again, I'm not digging into this today. I'd be happy to talk more if you're interested. But here are the handful of recent papers or reviews that I think are very nice. Machine learning that actually performs better than our traditional models. I hesitate to that because they are a little black boxy. I don't know what is driving the decision to make a change. And I think we should know that sort of information. And so does the FDA. So in order for that to be an FDA approved product, it would have to be interpretable. You'd have to understand what went into it to make your drug dosing decision. Whole bunch of other fun topics we don't have time to talk about that could potentially be used to improve our therapeutic drug monitoring and our outcomes related to immunosuppression. And so I think this is my vision for the future, where we can take biomarkers, home sampling, augmented intelligence, machine learning, whatever you want to call it, to help us make these decisions, provide additional feedback, continuous support for our patients via mobile health technology. And there's lots that we can do moving forward. So thank you guys so much for joining us, and we'll take questions after the next talk.
All right, thank you, Abbie, for that wonderful precision dosing talk here. Actually, let me share 1 second. My screen here. All right, guys. So I'm going to take a little different aspect here relating to novel maintenance immune suppression regimens and talk more specifics on belatacept and place in therapy. I'll start by saying I have nothing to disclose as it relates to the presentation, but I will be talking about some off-label use of these meds. Objectives for our time today reviewing Bella is to look first at the literature that supports belatacept use in kidney transplant. Then we'll dive into describing innovative maintenance immune suppression regimens with the co-stimulatory blockade, and then look specifically at outcomes and novel places in therapy with belatacept-based regimens. So for our residents and newbies in the transplant world, I did want to just bring to light mechanism of action of belatacept. You all are, I'm sure, aware it's a selective T-cell co-stimulatory inhibitor, binds to CD80 and 86 on the antigen-presenting cell, which stops the interaction with the CD28 receptor that is needed for signal 2 to activate the T cell, so that there is not further proliferation of T cells that are gauged against that antigen. It is dosed based, and this is all in kidney, on label for kidney only to prevent rejection, dosed at 10 mg per kg post-op day 1 and 5, weeks 2, 4, 8, and 12, and then goes to a maintenance of 5 mg per kg every month thereafter. It is infusion. It's 30 minutes and very well tolerated overall. There are requirements for EBV IgG seropositivity, given the data when the drug was being investigated with increased incidence of post-transplant lymphoproliferative disorder and those that were seronegative. So need that positivity. Again, well tolerated. Potential for infusion-related reactions, we just honestly don't see it very often. There are very, very rare risk of progressive multifocal leukoencephalopathy, PML, that PTLD we just talked about. So overall, just monitoring for infections, malignancy, just immune suppressing potential things with having this agent on board. So we're going to take a step into literature that you guys are very well versed in, have read, and part of residency experience have done. But this is the data that allowed for the labeling for kidney transplant with belatacept. This is the benefit study, and the benefit study was a study investigating low immunologic risk renal transplant patients, and there was a big group of them, 666 patients. And what they did is all of the arms received basiliximab, IL-2 inhibition for the induction, and then there were 3 arms, a cyclosporin-based regimen with mycophenolate and steroids, and then 2 belatacept-based regimens with varying dosing strategies. So a more intensive with, you can see here in the box, a lot of doses at any given time over the weeks with a load of the 10 mg per kg and down to 5 mg per kg every 4 weeks thereafter. And then a less intensive, which is what is on label now for kidney transplant. And they investigated graft survival overall, and you can see in comparison between the 3 groups, graft survival was good, comparable between all 3 groups. Where the importance came and place in therapy for belatacept was renal function. You can see differences here. So better preserved renal function in patients receiving belatacept versus those on a standardized maintenance immune suppression regimen like cyclosporin. But one thing I wanted to highlight, you get good renal function, but you do have risk for rejection. There were more rejection events in the belatacept, both arms, and only 7% in cyclosporin. There was another study looking at extended criteria donors with belatacept use. This is the Benefit EXT study. Same regimens, same 3 arms for maintenance dosing, but they looked at these extended criterias and found comparable graft survival. Renal function still was numerically better in patients receiving belatacept. And acute rejection rates were similar in these extended criteria donors. They looked at longer-term outcomes at 7-year results out of the benefit study, the initial one, and with longer-term use of belatacept did find a 43% reduction in death and graft loss with your more intensive or the less intensive belatacept-based regimens versus standard cyclosporin. And you can see here in the graphic at the bottom right that renal function was preserved over time, much more so than with cyclosporin. So better renal function, rejection still a little higher in Bella, but kind of, teetered or stabilized out with time. Most of the rejection happening within the first year compared to cyclosporin, and infection rates were similar in this group, and cancer rates were similar in these groups. So takeaways with belatacept from the literature that we have all well read, better renal function, and really the reason is because there's no calcineurin inhibitor in play. Similar graft and patient survival, but that comes with potential higher acute rejection rates. These regimens still had steroids involved and metabolic complications of steroids. How are those on the in the long term? So really, where is the place in therapy? Are we comfortable with the potential for rejection, and how do we think about these things overall with belatacept? So I want to turn us now to this question on how to tackle rejection risk, and how can we design our regimens to help minimize that risk? So the data lends to showing that most of the rejection was seen within the first 12 months. When I think about 12 months, I think about induction. Maybe induction will make a difference because that's really those first 6 months or so. If you're using alemtuzumab, maybe a little bit longer. But investigating the data behind this, you can see highlighted the benefit study here. We saw those acute rejection rates with the Bella versus cyclosporin. There was a study out of Emory, Adams et al. In 2017 looking at basiliximab and looking at varying dosing for maintenance with belatacept, TAC-based, and then a Bella, mycophenolate, and TAC combination. And with basiliximab use, there still was higher rates of rejection. And so looking more at lymphocyte depletion, maybe that's the key. Ferguson et al. In 2011 looked at the use of antithymocyte globulin and looked at 3 different regimens, and these were without steroids. So looking at tacrolimus and mycophenolate, belatacept and mycophenolate, or belatacept and sirolimus, and TAC and mycophenolate had the least rejection. The second least was belatacept and sirolimus, but when used in with the antithymocyte globulin and Bela and MMF, had about a 15% rate within the first year of rejection. So maybe you can use thymo, but you got to think about your anti-metabolite that's used in addition to belatacept. Woodle et al. In 2020, that the BEST study looked at differences in lymphocyte depletion with alemtuzumab versus antithymocyte globulin, looking at different varying regimens with no steroids, or actually a steroid withdrawal by post-op day 5, and looked with alemtuzumab, belatacept, and mycophenolate. There was 15% rejection first year. Looking at antithymocyte globulin with Bela MMF, 22% compared to the standard of care with standard orals. We had only 4% at the year. So induction is kind of variable. Maybe it's induction and oral maintenance that is the case to designing that regimen to mitigate that rejection risk. So highlighting again the Ferguson with the antithymocyte globulin, least rejection was when you put an mTOR in the mix with Bela, and was comparable to a standard oral with tacrolimus-based regimen. UCSF has great data on thymo with belatacept, mTOR, and prednisone, and their rejection rates in the study reported was 0%. So adding a little steroid maybe with the mTOR on board. Emory's data with the IL-2 with TAC at varying times in addition to belatacept and mycophenolate, so TAC at 5 months, TAC at 11 months. The longer you kept TAC in the mix, less rejection. And then we have data here. One of our surgical residents looked at all of our belatacept use, and we use a regimen of alemtuzumab induction, belatacept, and sirolimus. And at 3 years, a little bit longer follow-up than these other studies, lended to only 10% risk. So mTORs, I think, may be a place in pred versus TAC. So there's still, how do we design it? How do we think about this? And one thing to think about is, how does this rejection occur? Like, what are the markers of this rejection? And understanding that, I think, is important. So the early rejection episodes seem to be linked more to memory T cells overall. And that is because these memory T cells, what they do is basically they are negative, or they do not express CD28. So they're not checked by belatacept. Belatacept blocks CD28 to be able to stop that signal too. So you've got this cell line that's unchecked, and then you've got other T cells that are checked. So those unchecked cells are what may be leading to that rejection. And mTORs have a place. They target these differentiated cells that do not express CD28. So synergistically, using mTORs and belatacept together give you an ability to suppress all T cell lines. So when we design these regimens to prevent rejection, we need to think about induction, rejection high within the first year. Maybe we need to be putting lymphocyte depletion in the mix, thinking about the oral maintenance. mTORs might be of benefit. If we don't do mTORs, then maybe a little low-dose TAC with prednisone, thinking about that too. But big takeaways is still, so we have preserved renal function with belatacept. Graft survival is excellent. Yes, there may be rejection, but the rejection is steroid sensitive and it does not affect that graft survival. So these are things to think about. Just because we see rejection, and as clinicians, we always think about rejection bad, but they're easily treatable and the kidney does better for the long term in comparison to the calcineurin inhibitors. But it still is nice in outcomes metabolically outside of the kidney, thinking about avoiding CNIs, avoiding prednisone. So anything we can do for overall patient survival important as well. So thinking about this in design is important. Now we're going to talk about place in therapies. So do we use belatacept for all, or is there niches to where we use Bella? And this is interesting, and it's going to be a little whirlwind, so hang in here with me. So first, we're going to talk about preserving renal function, and this is with de novo belatacept use. So here at Duke, this is the reference I wanted to bring to light that we published or will be publishing with alemtuzumab-based induction belatacept with sirolimus, allowing us to avoid our tacrolimus and steroids. And in our cohort, there were 96 patients. They are low immunologic risk. You can see here living donors were the majority, 82% of the recipients receiving those. They were younger patients, male and white, and did not have preformed antibodies no preformed DSA coming in, and we're all EBV IgG seropositive. And you can see EGFR, excellent, all the way out to 3 years with the belatacept-based regimen with the mTOR. Rejection rates were very low within the first year when we give alemtuzumab. 3 years, 10%, still low in comparison. There were some DSAs that did pop in the patients with sustained DSAs, low-level MFIs in this cohort, but excellent patient graft survival. Did have some infections, and we'll kind of talk about that with some consideration, so being mindful of those. But the takeaway, and from our experience here at Duke, is that patients don't tolerate mTORs very well. 50% of patients remained at 3 years on a belatacept and sirolimus-based regimen. 34 had to come off of sirolimus altogether. We had to add steroids in the mix to be able to get patients to stay on the regimen. But luckily we did be able, effectively 93% were able to avoid CNIs. So good data, but we have to manipulate dosing with other agents to kind of help with tolerability of those mTORs. Now, what about later on for renal sparing belatacept use, and conversions later may be effective to help spare the kidney from CNIs. And this is reflected here in a JSN 2021 article looking at belatacept versus tacrolimus-based regimens in patients that were kidney transplants switched anywhere from 6 to 60 months after transplant, and compared survival, and it was comparable between at 24 months. Rejection rates in these groups were low, and EGFR, you can see here, was better even when you convert them later. So you're able to help preserve renal function anytime you can get patients off of the CNI. Similar rates of infections and discontinuations between the group. The next area is delayed graft function. Patients that have DGF, and we're trying to think about long-term outcomes with the kidney because it just took a hit, the long cold ischemic times, other things may have compromised function and survival. So maybe early conversion of belatacept has benefit in these patients. And this is represented in Clinical Transplantation 2017 with early conversion happening within 30 days of transplant to a belatacept-based regimen and off of a CNI. And this was 20 patients, all kidneys, with a primary outcome of EGFR at 12 months. And at 12 months, it was 54. So kidney came back and functioned well with the use of belatacept. But I think the way that I really like to look at this is the secondary outcome where they looked at EGFR at 30 days post-conversion. Before they converted, the EGFR was 16 on the day of conversion, and then 30 days later was 43. So anytime get off that CNI, and belatacept allows for that, even in these delayed graft function patients, the kidney is functioning well, but still 20% rejection rate in this group, similar patient graft survival in the patients that were converted to other patients that we see in transplant. Another area for novel use of belatacept are in de novo DSA development. Benefit trials and the Benefit EXT looked at de novo DSA development, and you can see in these graphics here in the Benefit and the Benefit EXT on the left and the right, that patients that received belatacept-based regimens at 12 months had a much lower development of DSAs versus those on cyclosporin, 12.1% in the benefit trial. And that also blended true to those extended criteria donors. So Bella, that co-stimulatory immune modulating effects helped to decrease DSA development when used de novo. And we investigated that here last year. Our current PGY2 resident, who was a PGY1 interested in transplant, did this. And here at Duke, single center retrospective cohort analysis of kidney transplant patients receiving belatacept versus TAC, we investigated the development of DSAs. We deemed our primary endpoint as clinically significant, so MFI is greater than 1,000, and compared patients who received belatacept versus tacrolimus, and not statistically significant, but did find a trend towards less DSA development in those receiving belatacept. And there was a clearer cut when we looked specifically in our secondary endpoints on class 2 DSA development, with only 3 patients developing the DSAs versus 6, or 6 versus 13% in the tacrolimus. So numbers were low, and groups weren't very well balanced, but still belatacept may be of benefit for patients in preventing DSA development. And this is also true when looking at patients who have preformed DSAs coming into transplant, trying to prevent further issues with development of ABMR. And the Bellicor study, which is a pilot study published in 2019, investigated this as a multi-center prospective trial with a retrospective control group. And 49 patients were included who had preformed DSAs with MFIs of anywhere from 500 to 3,000. And they started de novo belatacept, mycophenolate, prednisone with thiamo induction. And what they found is that there was a significant decrease from pre to post, with the class 2 DSAs decreasing, no ABMR at 1 year, and excellent graft and patient survival. Still had rejection, but there was no ABMR that developed. So maybe a place is these patients that are highly sensitized coming in with preformed antibodies, that belatacept can help with that co-stimulatory blockade. Another place is with chronic rejection, patients that had developed chronic active antibody-mediated rejection. How do we help them to preserve kidney function as long as we possibly can before requiring retransplant? And Campara in Transplantation 2021 published an article looking at 19 patients with biopsy-proven chronic active antibody-mediated rejection who converted from TAC to belatacept at a median of 44 months after transplant. And they looked at histologic comparisons, pre and post conversion, and they found at 9 months after they converted to Bella, that there was no worsening in microvascular inflammation or any chronicity. And they actually found improvements in mean total rejection scores and improved AMR rejection scores. And you can see here this from pre-conversion in the graphic to post-conversion with belatacept, that there was a preservation of renal function in the setting of having chronic active antibody-mediated rejection. So this kind of also lends into these whole antibodies and antibody-mediated rejection, Bella with desensitization. So using, we have data, actually our group here at Duke, Dr. Keck and his cohort were able to look at non-human primates who were maximally MHC mismatched. And these non-human primates, they gave lymphocyte depletion and then did Bella and TAC or Bella and sirolimus. And there were only 14 rhesus monkeys that were included. But what they found is that there was a significant reduction in rebound DSA after transplant when compared to tacrolimus. So these highly sensitized patients were able to be transplanted with good outcomes for the non-human primates. And we're investigating this now in humans, the ADAPT study, looking at carfilzomib with desensitization with belatacept, and using these for our patients with CPRAs of like 99.99% in an effort to be able to get them transplanted. So we're hopeful in the next couple of years that this data will be published and maybe something that we can use in all of our institutions for these highly sensitized patients. Now, I didn't forget about my thoracic colleagues. I did a lot of kidney heavy data review, but for thoracic transplant, I'll briefly go through because I know time is limited here, but lung transplant, there's evolving data with belatacept. For those who have had, who were CNI failures, being able to have an alternative with belatacept was investigated and published in a single center retrospective case series in 2018, and found that in patients who converted there were changed over to Bella, that there was no difference in rejection rates in that group. Infections were similar statistically, and there were 2 patients that went on to have clad progression, but no deaths, and EGFR was better with Bella on board. So an alternative to those who fail CNIs. And then renal sparing has been investigated in retrospective case series in 8 patients who had acute renal failure or had refractory renal insufficiency, who were put on a belatacept with a reduced dose CNI, and found that EGFR was either stable in 2, improved in 5 patients. So this is one piece. And there was 1 death, a multi-system organ failure, and that was an infection-related outcome. So being mindful about infections in this in these belatacept uses. Now, de novo use, I kind of looked at, and maybe people on this call have a little bit more experience here, but in the use out of the gate, there was a pilot randomized study at 2 sites published in 2022 that had 27 patients using belatacept de novo with a thymo induction, and they actually had to stop it early because 6 patients died in the Bella arm. So maybe de novo use, not so much. But there is data with AMR with Bella, and there were 13 patients with active AMR who were placed on a belatacept with CNI-based regimen and had improvements in the FEV1 at 1 year, and DSA levels remained stable. When looking at heart, there was similar, so renal sparing improvements with switching patients over either de novo or doing a conversion for CNI sparing. Found rejection did occur, but renal function did improve in 50% of patients. And in the top study, and then the second study there, the EGFR improved in 40 patients who were switched at 3 months. And then donor-specific antibodies for patients that have developed donor-specific antibodies after transplant, putting them on Bella with a reduced dose CNI in 21 patients, found that graft function stabilized. They had only 1 ACR event. Infections were different, with Bella being more so than those who remained on CNIs, and then the EGFR did improve. Now, I couldn't be a good pharmacist if I didn't do practical considerations, but I know time is not boding well for me, so I'll briefly run through. So when you're thinking about these Bella regimens, make sure that you are looking at that EBV IgG positivity, making sure you understand how infections may play with putting on this high degree of immune suppression. That also relates to malignancy history, and then make sure that they're robust enough to be able to be on this drug. And then it's expensive. It's one that has infusion-related costs in center or at home, and then cost of the meds. And I have a little graph or numbers here calculated for an average weight patient. And then being mindful that there is no copay assistance for patients that have Medicare or Medicaid through the manufacturer. You have to identify infusion centers, and then depending on what induction you use, here at Duke, we do alemtuzumab, but there's no on-label use by the FDA now for kidney transplant. So we have to do all this special ordering and make sure we have enough in stock, and can be a little bit of a headache depending on the novel way that you design the regimen. And then all these questions come up with Bella use, like what do we do when we have patients on it relating to them with active infections that develop? Do we dose reduce? Do we hold a dose? What do we do? Do we convert them? Also, long-term management. Do we keep people on 5 mg per kg every 28 days for life? Or do we stretch things out? There is some data out of Emory that suggested that patients that are low immunologic risk, maybe they can go to every 8 weeks if they're more than a year out from kidney transplant. And then how do we manage patients on Bella with malignancy? And then how do we manage and dose patients who are obese with belatacept and what are considerations there. So still some unknowns, but with Bella, there are maybe some unique places, novel ways to design it. So overall, multiple novel designs in conclusion here. Belatacept can be used for varying indications, but still always as a pharmacist, we're thinking about those logistics and dosing and making sure that the patients are able to tolerate it and get the drug to do well with it. All right. So with that, I think we are open now for questions.
Thank you guys so much for your presentation. It looks like we do have a question for Dr. Byrns in the chat. So for our second speaker, Dr. Byrns, what levels of sirolimus were you aiming for in the Bella and sirolimus study, and did levels impact tolerability, i.e. what made them come off of the sirolimus?
That's a great question, and you guys might be a little shocked. So we do sirolimus, our goal by protocol is 8 to 10. And patients do not tolerate trough levels of 8 to 10. So what we do is we often see development of mouth ulcers, we see potential edema, we have wound healing issues, and patients, what we'll end up doing is lowering our trough goal and kind of spread out. So a 5 to 10, or we'll go to 3 to 8, very patient specific in the scenario of kind of their PRA and what they were, how far out from transplant. But we kind of bring it down. And if there comes a point where we just don't feel comfortable, like when that 3 to 5 range and we're still within the first year, we'll add a little prednisone on. Yeah, we'll add a little prednisone on in hopes that we can, and then there comes a point where we just have to call it. And some patients will end up on an MMF and pred-based regimen, or we add a low dose TAC in there. So it is 50% of patients just can't do it for the long term.
It looks like we have another question. So again, how do you manage BK virus infection in your belatacept regimens?
So it is with BK difficult. We give alemtuzumab, which is very immune suppressing. And I'd say in our cohort, we have about a 30% rate of BK in our kidney patients. And what we do is dose modify. We first try to bring down our mTORs or put them on MMF and bring it down, or hold it or hold the mTOR. And then we have done a myriad of things with our belatacept regimens. We have some patients that are on Q6 weeks. We have some that are on Q8 weeks. We have some that are on half doses. So instead of 5 mg per kg, we do 2.5 mg per kg. And cross our fingers that all goes well. At least we have a marker of creatinine that we will be able to watch closely. And we do HLAs, and we also do Alicia's here to make sure that nothing is trending in the wrong direction. But we do keep close eyes on these patients. It's always hard with the Alicia's. You can't, with the active infection, be able to interpret. But if we see a big trend up and we see,
I can't hear you.
See, that might be an issue.
What?
I think there might be another question for me too. Do you have issues getting access to Campara through the distribution program? And the answer is yes. We had to actually go back and edit we have the template, like when you're doing the ordering that the manufacturer requires, but we put these different verbiage. There's like a spot in there where you can talk about literature-based and the validation for why we're using the regimen. And we had to go back and kind of rephrase that in order to get a drug approved. And then here at Duke, we long ago, what was it, 10, 15 years ago, when it was still on label for kidney transplant, only asked for allocating 30 vials for our entire institution for all patients to use outside of transplant and with transplant. So we run through that, and then we have to do the patient specific through the distribution program. And I'm afraid there will come a point where we may have even harder potential getting drug through that distribution program. But we're in talks now of maybe using thymoglobulin instead of alemtuzumab as a way to kind of get more access and transplant more patients with Bella.
Thank you so much for all of your responses. It looks like we also have a question for our speaker, Abbie. So for Dr. Leino, are there any tips or tricks on how to convince folks to go beyond troughs? And when I bring up AUC monitoring for our patients, I tend to get pushback from providers. How do you tackle that situation?
So I think that's our big problem, right? And so that's one of the projects that I'm starting to work on is implementation of this and like what are people's opinions? What do they know about this literature, right? Like until I went back to get my PhD and really started reading all of this primary literature, I just kind of, had the opinions of the people who trained me, right? And most people's opinion is we just get tac troughs and mycophenolate and we empirically do it and we're pretty good at it and our rejection rate's only 10%, so what we do is fine. And so how do we move beyond that? And so that's part of, what I spent some time in my PhD learning is, what is the science behind implementation? How do you get stakeholders on board? And so I will hopefully be able to provide some additional information and support you in that decision. But I think it's starting to do it in the patients who you have a problem, who you think their AUC or their total exposure is not what reflective of their trough. And that's kind of what they've seen here at Children's. And while I wasn't involved in getting us to this point, is they just started doing it in a handful of patients, kind of driven by the pharmacology department saying, hey, we could do this for you. Let's do some research in it. And so they started seeing it and doing it. Same thing kind of happened across the street at the University of Cincinnati when I was there as a fellow. We were doing mycophenolate AUCs in our study patients. And then the clinician saw that, oh, maybe not therapeutic as often as we think, and there is benefit to this. And so it's just kind of, if you can get it in that first patient and you get lucky and their AUC is out of whack and you change it and it helps, well, then the next patient, they're a little bit more willing to do it. Presenting journal clubs, right? Finding this literature and bringing it to them and saying, hey, look at how many percentage of patients are not where we think they are. Because they may not be reading it, right? I don't think transplant pharmacists are reading pharmacology journals. I certainly don't think your surgeons are reading pharmacology journals for the most part. So bringing it to just the data that's out there to them, asking for it, hopefully getting some positive results when you do obtain it, and then thinking about implementation science, and hopefully I can help you get some data from that perspective since now I have time for research. How close are we to home DDM? I think probably I got to answer this fast because we're pushing our limit, but so I think that the results from these newer home sampling devices are very good. They correlate very well with your venipuncture samples. There are some centers that are doing it as standard of care. Again, some of those European centers do it as standard of care. I think you could do it now if your center was motivated and wanted to do it. Likely you will hit Robux with your lab and them wanting to start running all of these samples for you. But I think the technology is very good. If you have a very good assay and your lab will work with you, I think you could do it now.
Thank you so much again to our speakers and to everyone who asked a question. We'll just take a short break until 12:25. So please come back at 12:25 to continue with session 3. Thank you. Welcome back. I hope everyone enjoyed their break. We'll now start session 3 on novel rejection strategies. I'd like to introduce our first speaker, Dr. Nicole Pilch. Dr. Pilch received her Doctor of Pharmacy from the University of Wisconsin-Madison. She completed postgraduate training at the the Medical University of South Carolina with the PGY1 Pharmacy Practice Residency, followed by a PGY2 Critical Care Pharmacy Residency. After residency training, Nicole completed a Master of Science in Clinical Research and a Fellowship in Transplant Clinical Research at the University of Cincinnati. Nicole remained at Musk in 2006, where she maintained a clinical practice in the care of patients with end-stage kidney and liver disease and abdominal solid organ transplant for over 10 years. Then in 2015, she pivoted into a role as the director of the Quality Assurance Performance Improvement Program for adult and pediatric solid organ transplant, and later for the oversight of the QAPI program for Musk Health System. Throughout this, she maintained a clinical practice in the post-transplant kidney acute clinic, and Dr. Pilch is currently a tenured professor at the Medical University of South Carolina and is fortunate to work with many transplant pharmacists throughout professional organization committees and educational initiatives. Following her, we have Dr. Alicia Lichvar. Dr. Lichvar graduated from the University of Pittsburgh in 2013. She completed her residency training in solid organ transplantation at the University of Pittsburgh Medical Center. From there, she completed a transplant pharmacy fellowship at the University of Cincinnati, where she completed her Master's of Science in Clinical and Translational Research. She worked at the University of Illinois Chicago as a clinical assistant professor and clinical transplant pharmacist, caring for abdominal transplant recipients. She then served as PGY2 residency program director at the University of California, San Diego Health, where she worked as a clinical specialist in kidney, liver, heart, and lung transplantation. Currently, Dr. Lichvar is a clinical transplant pharmacist at the University of California, Irvine, caring for kidney and pancreas transplant recipients while establishing their outpatient transplant pharmacy service. Her professional research interests include novel immunosuppression strategies, postgraduate education, and burnout. Please join me in welcoming Dr. Pilch.
Hello, everybody. Can you hear me? I'm trying to do something on my phone. My other computer has challenges with its audio. So hopefully we can go ahead and get started, and I'll ask Alicia to come on the screen as well, because we're going to do our talk just a little bit different. Our subject was novel rejection strategies, and we are hoping that we can do this a little bit different and sort of make it a little bit more real world if we could. So we are going to discuss the history and diagnosis of antibody-mediated rejection in liver transplant recipients specifically, and then we're going to kind of compare and contrast those modalities for treatment in liver transplant recipients, and then look at some other allografts and their management of antibody-mediated rejection. But we're going to do it in the context of some cases. So, you know, all of us have been there where we need to phone a friend. And I think that's typical of right now, especially across the world. So in this fictional scenario, hopefully all of you can pretend that you are the friend I'm phoning as well. But in this case, I'm phoning Dr. Lichvar across the country, since she's on the West Coast and I'm on the East Coast. She's probably more awake than I am, with more, you know, coffee, since she's still in the morning and I'm in the afternoon on the East Coast. So let's go ahead and get started with the first case. So if you can imagine a case where you have a patient who's admitted with a chief complaint of a fever, elevated liver transaminases and bilirubin, and the history of present illness for this patient is a 45-year-old white male with a history of autoimmune hepatitis who underwent a liver transplant 30 days ago. And then 3 days ago, the patient presented to the clinic with abdominal pain and increased drainage from a remaining abdominal drain. The liver transplant was completed by delayed abdominal closure. The patient experienced some AKI requiring renal replacement therapy, had a prolonged ICU stay, and this was an ABO compatible donor with a 21-year-old male donation after cardiac death donor who had a pre-procurement sodium of 158. And so that's why we can see a delayed abdominal closure. This patient had a very low sodium at transplant. The patient was given basiliximab induction at the time of transplant, along with standard institutional steroid taper, some Cellcept and some delayed tacrolimus in the setting of the AKI. And on day 14 of the hospital stay, the patient developed elevated transaminases and a fever and underwent a liver biopsy, which demonstrated a severe cellular rejection, and the patient was treated with high-dose corticosteroids, and the transaminases dropped to their post-transplant nadir, and so everybody had a sigh of relief. But as we progressed with this case, you can kind of see this patient's level of immunosuppression over time. So at day 0, you know, we had this delay. We really didn't get to therapeutic tacrolimus levels by most institution standards by about day 14. And you can see this is when the patient was treated for rejection with methylpred. And then the patient sustained decent tacrolimus levels and then was beginning their steroid taper by day 30. On day 30, so imagine that's today, Saturday, you have a repeat biopsy that reveals an RAI6, and then some necrosis was noted on the gross biopsy, which was initially thought to be secondary to scarring from a previous biopsy site. I'm sure you all have been there when your surgeon says, oh, I think we got the previous site. That's, you know, that's probably what it is. At that point, the patient was given some thymoglobulin, and after 2 days, we didn't really see any appreciable improvement in their transaminases. And at that point, AMR was suspected. There was C4D focal positivity, and the retrospective cross-match, we went ahead and performed just in case, and it showed a weak B-cell positive cross-match. At that time, we also got some DSAs, and the DQ2 was 87,000, and the DQ6 was around just over 10,000, or 10,000 plus, I should say. You can see following that, on the day of admission, so before the treatment started, we had an elevated T-bilirubin of 6.2. You can see the transaminases weren't markedly elevated, they were just slightly elevated. And then over the course of giving thymoglobulin, we really didn't see that drastic of an improvement, right? So we saw just a slight drop in the T-bili and, you know, not an appreciable drop in the AST, you know, in a very, you know, from a lab, you know, error perspective, not really any drop in ALT either. So at this point, I got to call Alicia and see, you know, what do we think we should do with this AMR patient that we're treating with T-cell therapy, and we're not showing any improvement.
Thanks so much for the phone call, Nicole. I've taken my body out of the Pacific Ocean after surfing on this beautiful, beautiful morning, November morning. And this is a call that you know, having friends on multiple time zones, phoning a friend is usually the smartest because every approach is a little bit different. Everybody wants to see, especially in the era of these NRP devices and pumping of livers and taking more marginal livers, we're starting to see a lot more rejection cases kind of take hold. So in liver transplant, for the most part, antibody-mediated rejection was thought to be really infrequent with a minimal impact on the graft. If you've been training, you know, in any part of the last decade, you may or may not have heard a transplant surgeon go, the liver is a sponge, the liver soaks up antibodies. We don't need to do a cross match. Sometimes they're just done retrospectively, but the incidence of acute AMR is really low, 0.3% to 4% from retrospective studies. And there's really at this point a general unknown instance of chronic AMR. When they polled centers in 2013, you can see that most of them believe AMR exists, 91%. You know, 9% are going to be flat earthers. That's okay. AMR is very nebulous at that point in time. But 46% believe that despite AMR being out there, only half of them believe that it could cause an allograft injury. And so for us, AMR was really only introduced into the BAMF working group on liver transplant pathology in 2016. So for those keeping score at home, for those who need a little, you know, point of reference, Mad Men was still on TV. We were in a very different but also similar presidential election year. I was a fellow, so that makes it feel very old and very long ago. And when I was in training, we also didn't have a consensus on if this even existed at all. So basically, yikes. Now, currently, if you look at the 2016 BAMP criteria, really you had these two tiers of antibody-mediated rejection. The first being like a plasma cell-rich rejection, and it was pretty strict in terms of what criteria you needed to fulfill in order to meet that criteria. So you see the three criteria, one being portal and or perivenular plasma cell-rich infiltrates, lymphocytic cholangitis, but it's not absolutely required, optional, and then original disease, something other than autoimmune hepatitis, because they can look really similar on biopsy. For acute AMR, in this iteration of the BAMP guidelines, you really needed all four. And we'll really talk about, as we get into the studies, you know, why that's the case. Histopathology, so basically how that manifests is portal microvascular endothelial cell atrophy, portal capillary and inlet venule dilation, portal microvasculitis, portal edema, active lymphocytic and or necrotizing arteritis. You'll see there's some key words, you know, if you practice in kidney transplant, if you practice in heart transplant, you know, keywords like microvascular inflammation and arteritis might pop up as being familiar, you know, touch points in other pathology terms. Having positive DSA. Remember, you might have heard the liver is a sponge. So in that vein of thought, you know, the liver sucks up DSA. So in some patients, they might be DSA negative, but DSA positive within the graph. But according to these initial guidelines, they had to have a positive serum DSA. Diffuse microvascular C4D deposition, which is pretty standard. Although you can see in other organs, other allografts and kidney transplant being the most common example, you don't need that C4D positivity to make a diagnosis of AMR. So liver transplant is a lot more exclusionary in that way. And then basically exclusion of other insults. So all four are needed. And then anything beyond that is really indeterminate. Again, you can see that with the AMR BAMP pathology, which I won't like really harp on, there are different scores. You know, we look at the 8 score in liver transplant, and you can kind of see its manifestations, 0 being none, 3 being severe. And also C4D can also be graded in that similar fashion of 0 being none, 3 to diffuse, in addition to having, you know, different fibrosis and ductopenia scores. So things to look out for that are very different than other allografts. For us as well in AMR and liver transplant, we traditionally in ABO compatible transplants, so they're thought to be really resistant to AMR. Again, the liver can regenerate, the liver is very forgiving. We didn't have to do cross-matching. And many centers don't do cross-matching with ABO compatible transplants unless there are issues that necessitate a retrospective. For us, looking at more modern data, there are, you know, some risk factors that are associated with liver AMR, and big one is DCD, especially if your center is using the NRP pumps and taking more risk-adverse DCDs than they might have in the past before that technology was around. You're accepting a lot of warm ischemic time, and that is a huge, huge inflammatory burden upon reperfusion. And in that way, also distance between the donor and the recipient. Again, anything that can extend that cold time, extend that warm time. HCC exception. So you have these patients that have a MELD NA or a MELD listing that are much higher than what they would be otherwise, because they're getting exception points for having HCC, trying to get that transplant while they're still within the Milan criteria. And then something that we saw quite a bit when I was at the University of California, San Diego, was the use of immune checkpoint inhibitors. Patients received a good deal of this class of medication for their HCC while they were on the wait list, while they were being evaluated for transplant. And for us, as a 150 liver transplant center, Their time on the wait list was very short-lived, so they might not be as removed from these immune checkpoint inhibitor therapies as we would like to see ideal, and that increases their risk for rejection, specifically AMR. For us, and this is, old hat for Nicole, there are a lot of treatment modalities. I have always referred to it as basically breakfast of the dog. You can do methylprednisolone. Typically that's a pulse of 1,000 milligrams, 5 to 6 doses. IVIG and plasmapheresis are pretty much mainstays in any antibody-mediated rejection. In liver transplant specifically, that tends to be around 4 to 6 sessions. And for IVIG, you can do supplemental doses in between the plasmapheresis sessions, and then generally larger doses of 1 to 2 grams per kilo can be given after that. Some centers, as you'll see, have chose to also add on rituximab. Typically, the 375 mg per meter square per week, 1 to 2 doses tends to be, the approach that's taken. And then even some centers have used Velcade, and I can talk to you about the practicality and my practice experience with Velcade and liver. So when you think about liver AMR, and you think about essentially the two modalities of, I don't believe this existed until 2016, and this has been here all along, you really fall into 2 camps. You can go big or go home, and really what the thought is, there's no safety net after liver transplant. If you don't succeed in reversing this, that patient's either going to need a retransplant or they're going to die. So if the allograft goes, the patient goes with it. And so reversing the damage before it gets out of control is one approach to AMR treatment. You have the other side, and because this is a CE talk, I have it censored, but basically you start messing around, you're going to find out. Liver transplant, due to the nature of the anastomosis, due to the nature of the location in the body that the liver is, it is an infection hellscape in terms of intra-abdominal infection risk, fungal infection risk, biliary infection complications. It can get really bad really quick. And with that, you can also treat very aggressively, but then run into the issue of, we need to retransplant them, but oh God, they're too sick to retransplant. And I've seen that happen live in practice. These treatments also come with a really high mortality relative to kidney transplantation and other allograft AMRs. And, there's also the thought of get the liver started on its recovery, and, the liver will recover on its own. So why do we need to be so aggressive? So I think to understand this, you get one really cheaply made smart art. We need to dive into the history, and we need to understand kind of the treatment modalities that have been out there before this 2016 establishment of AMR and then after. So with that, the data that we have is not great. The data that we have in kidney transplant is also not great, but the data in liver transplant is also far worse. There are no comparative trials. You have extremely small case reports and case series. There is an incredibly high error effect. And so if any of you have seen Mad Men, which was also being featured in 2016, it can be best summarized as not great, Bob. The data is not great. So initially, and these are going to be color-coded in a way that introduces the rationale in a couple slides, but essentially I want you to take a look at some of the immunosuppression that is listed on this slide. And I know it is Saturday. I know it is still morning hours for me. I know that it is later in lunchtime on the East Coast, but when the group looks at this immunosuppression slide in terms of maintenance regimens, what does the group think? What do you think of this maintenance regimen? Take yourself off mute and please provide your expert opinion. Please do not be shy. I am very over-caffeinated. What do you think? What do you think of these regimens that are on this slide? Anyone? Bueller? Do we like them? Do we not like them?
They look pretty old.
Yeah, they look pretty old. If these maintenance immunosuppression regimens lived in California, they would both need filler and Botox. They are quite vintage. Looking at some of the studies that have come out since then, even ones that have extended into 2020, you can see, low dose tacrolimus, MPA monotherapy. Yes, we've tried that for a little bit. Some patients in these case reports also were just on nothing because they stopped taking their immunosuppression. You can see cyclosporin being used. Cyclosporin finds its way into our maintenance regimens in liver transplant quite a bit due to the neurotoxicity risk, low threshold for surgeons to convert, just given, overall picture of the patient. And so just looking at these, you can see already what I'm talking about. The data is not great, Bob. And so really, pulling out, something to think of as we kind of go through these treatment regimens is, well, what did they come in with when they rejected? And what they came in when they rejected was not great. A lot of them were under immunosuppressed. A lot of them weren't on immunosuppression. A lot of them had withdrawal. And these are just the ABO compatible transplants. So as you can see, what they came to the door with was subpar. Starting from some of the older pre-2016 data, you can see I've color-coded these. And how I color-coded these is basically in terms of their outcome. So if patients survived, graft is good, they get green. If they died, graft is poor, they get red. If they kind of fall someplace in the middle, like, I gave them a yellow. Could teeter either way depending on how you want to split this up. Rostron is pretty much the first N of one where this was described in 2005. For us, you can start to see the Plex IVIG comes into play. They didn't have a Banff criteria to really describe AMR, so you'll see it be described in more vague terms, severe in terms of their REI DSA positive. Again, with the incorporation of methylpred in some of these patients, and then also, even thymoglobulin. So we can see that if you look at the studies on this page, you can see that there is no one way to do it. And in a lot of cases, you can start to see where the authors or the transplant group really started to panic. I think Campara is like a great example of that, of reaching for OKT3 and giving 10 doses. For those of us that have ever worked with OKT3, which is even predating my time, 10 doses is a lot of OKT3. And unsurprisingly, for patients where the death was described in these case reports, they died from either sepsis, ARDS, or some infectious complication that prohibited them from getting retransplanted. For us, you can see if there is an add-on in this pre-2016 era, it usually came in the form of rituximab and methylprednisolone, in addition to the plasmapheresis IVIG. Some centers started the incorporation of Velcade in tandem with what might have been happening in kidney transplant land. Again, in those examples, in this era, some patients did very well with that. But as you can see, even the more conservative approaches, they've had patients not make it to the other side. Leading into the 2016 data and a little bit beyond that, again, things to take away is that there are many different ways to do this. You can have many aggressive ways to dose. So you see these much higher, cumulative thymoglobulin doses, for example. In addition to that, in regards to use of rituximab and even Velcade, you know, when the liver rejects, it oftentimes takes the platelets down with it. And so you're really outside of the dosing parameters and really outside of the dosing recommendations based on side effects, based on the agents that you're really starting to throw on it to turn the ship around. Again, for the most part, when these deaths were described, DIC, sepsis, multi-organ failure. So these patients didn't just die, they really went out in a flashbang. And that should be a really word of caution for everybody. Very few of them got, if they failed their treatment, very few of them who get to the precipice of retransplant. I would say arguably some of the 2021 and 2024 data tends to be a little bit more robust. I'll spend a little bit more time on that. The Baradaran study out of Iran being one of the larger case examples that came out in 2021. As you can see, they didn't have a standard protocol, and 3 of their patients had also mixed rejection presenting with T-cell mediated rejection in addition to their AMR. If you look at the different treatment approaches, again, it really sticks to the methylpred, some type of plasmapheresis. Sessions really dependent on how these patients clinically were responding to the rejection and their initial clinical presentation and severity. The patients that had mixed rejection, you can also see a lot of them got thymoglobulin, rabbit anti-thymocytoglobulin in addition to that. Furthermore, most of the patients had optimization of their maintenance immunosuppression, especially those that might have just stopped their immunosuppression, and that action precipitating their rejection episodes. For the most part, patients in this larger, more modern sample, a majority of them survived. 7 out of those patients did well. 2 of them needed retransplant out of that 7, and only 1 patient died. Of note, what's most, impressive or worth calling out is this patient wasn't the patient getting the kitchen sink. This is a patient that could only tolerate 3 sessions of Plex and 3.5 grams of methylpred. So again, a conservative approach with still a poor outcome, further demonstrating that, there's no right way to do this. In addition to that, a more modern study from 2024, again, looking at 4 patients, again, demonstrating a wide variety in treatment approaches from methylpred and IVIG, just a dual combo, to methylpred immunoabsorption, IVIG, rituximab ×2, immunoabsorption plus IVIG, Velcade, rituximab. You can really start to see where the panic sets in, right? Again, most of those patients, 75% survived, no retransplants, but the 1 patient that did die died due to infectious complication. So again, who, what, when, where, it's really tough to say who's going to make it to the other side in liver transplant AMR. One of the last and most recent publications just further demonstrates the panic, the breakfast of the dog treatment regimens that we have. This was a 8-patient case series, majority white, majority, elderly, 61 to 70 years in age, and a majority 8CV, 8cc transplant population, somewhat reflective of the change in etiology, depending on what center you're at. And you can see here, there is no standardized way to handle this for the most part in real life practice. Over half get some version of Plex and IVIG, about half get steroids, flip a coin, half get Velcade, and then only 3 in this example got rituximab. For us, and what is similar to the typical storyline in AMR is, as soon as we're able to start those regimens, with regards to their presentation, you see that DSA is up. They start to get treatment. Depending on how saturated those single antigen beads are, there might be a bump, but with follow-up, those DSA decrease and eventually resolve, some even going away. And for the most part, with the exception of this patient number 8, there isn't a lot of discernible rebound in this patient population with this very, very, very limited case series. So aggregating all of these studies, we get a total of 70 patients, which, if you think about it, is really nothing. Of those patients, a bad outcome happened in 17 of them, and that's about a quarter of the population. So quarter of this group, you go after the rejection. Doesn't matter what you do. Doesn't matter if you mess around and find out. It doesn't matter if you treat aggressively and burn the boats. About a quarter of them end in treatment failure and death. Most of those patients, if you have a bad outcome, it's not the bad outcome is retransplant. The bad outcome is you go meet Jesus. So again, a word of caution that I think you see in practice where there is a stutter step to be aggressive because of the infectious complications that have been seen and the palpable risk that's out there. So this study proposed that there could be a management of AMR, but really it hasn't been battle tested. It hasn't been field tested. For the most part, I think it all starts with if you have maintenance immunosuppression that, is suboptimal, cyclosporin, mTOR, backbone, you're really substituting tacrolimus and you're getting levels up. You need to be more aggressive with the trough levels that you're targeting. Replacing azathioprine. Some patients find themselves on AZA due to like a history of PSC or UC, depending on center preference, and really just that needs to go away and you need to optimize. For us, if there is evidence of T-cell mediated rejection, really treat just according to what your center is already doing. For a lot of places, that's steroid pulse and taper, with the exception of more serious liver transplant rejections, which tend to be, above an RAI of 5 or 6, depending on center preference. They might go for thymo first, but most centers tend to just see how patients do with steroids, and if fail steroids, then thymo. In the setting of acute rejection, acute AMR, really you can lump them into mild, moderate to severe, and then recurrent. For mild, I thought with the proposal of methylpred pulse with a taper and optimization of the maintenance immunosuppression in the setting of steroid resistant rejection, progressing to thymo is reasonable, depending again on that patient response. Moderate to severe, again, backbone of steroids, I think is always very reasonable. Plus or minus thymo, depending on where that patient's response lies, what their CBC looks like, but then really pivoting towards using plasmapheresis. In this setting, thinking about how many sessions they can tolerate, initially you're aiming for that initial 3 to 4 sessions, to be honest. From there, really looking at not only the response to DSA, DSA and liver transplant takes just a longer time. A lot of the studies that are presented in the tables, these patients didn't clear their rejection for up to 6 months and some even up to a year. So really assessing, pausing, and then continuing with therapy is a time frame that you have in your pocket. You don't need to throw everything all at once unless it's very aggressive and very bad. Rituximab can be used, again, 1 to 2 doses. And then, if they're able to tolerate, you can consider Velcade. But for the most part, I wouldn't recommend, the study doesn't recommend going beyond 4 doses. If late AMR is suspected, at that point, I would honestly consider just pivoting to what can be done so that we can potentially set this patient up for retransplant. If it's recurrent, you can add bortezomib, or you can consider bortezomib. Again, knowing that there's a very fine line of what can we do to save this liver versus what's going to be the best setup for maybe just a retransplant scenario. Again, in the setting of chronic rejection, there's not great data. Keep in mind, all of the studies that have been presented that are out there in the ether for liver transplant, they deal with acute AMR. there's not a lot of great chronic rejection data. So again, at that point, it's really optimization of the maintenance immunosuppression and really gearing towards and repivoting towards relisting. So what do you think, Nicole?
Well, I have some questions. So yeah, this all makes sense. I think there's still a challenge about, what do you do with maintenance immunosuppression at the diagnosis? So is it something where you go ahead and shoot the moon and drive up their maintenance immunosuppression? And then how do you taper it long-term? And then when do you repeat your DSA during treatment to say that you're making headway? And then how often do you at your center, or really anybody on the call, look at these questions and write down your answers as well? Please tell me what you would do to approach your maintenance immunosuppression at diagnosis and long-term, and then monitoring of DSA. And then, how often should you biopsy? When should you repeat labs? And then are there specific patient factors that should weigh into this? And most patients will say, so when am I over this? When is this gone? What does success look like? What should your definition of success be, especially when you're counseling patients? So folks on the call, make sure you weigh in as well. But Alicia, help me with these questions, please.
Yeah. So I think when I think of maintenance immunosuppression at the time of any rejection, I think the first and easy step is to optimize. A lot of times, these patients are kidney patients. They don't have fistulas. There's going to be time and preparation with regards to admitting them, with regards to setting up therapy. And something you can do while they're waiting in line for plasmapheresis is optimizing that maintenance regimen, whatever that looks like for you. For us at the University of San Diego, that was TAC, that was Myfortic or Cellcept. We would be aggressive in their dosing, so we would oftentimes exceed the gram BID. And then, if they got through this rejection episode, if they weren't on a steroid before, congrats, they're on one now. So long-term triple immunosuppression was something that we would continue patients on. To answer your DSA question, for us, really waiting until the end of the completion of what would be considered the first round of therapy and monitoring at intervals in correlation with lab testing, right? What that means for us, is when we had a patient, we would get DSA, I would say, about monthly after, in addition to whatever labs that they would need to get. Sometimes patients get labs Q2 weeks. Keep in mind the burden of lab visits and things, and what could potentially already be a non-compliant patient. You're going to want to bundle things, but I would say at least monthly for DSA, but more often for their LFTs. And there's no good data on frequency, very similar to what's out there with other studies, but that's what seems rational, knowing that it's a slow resolving process. And then for biopsy, really, I think if you're not seeing the results that you would like, repeating that at least a month after the completion of their initial therapy and seeing where they're at. Some centers might be more aggressive and do 2 weeks, see if they're moving in the wrong direction, or if they're really stuck at this just very persistent increase in their LFTs, or bilirubin's getting worse. But keep in mind, rejection in the liver just takes time. It clears over months. So really the name of the game is being patient and using LFTs as that really nice surrogate marker to make sure you're headed in the right direction. For us, months down the road, I've seen some centers that have used this liver biopsy to see what is still salvageable from the liver. But that's, something that's more so center specific as well. Much like other allografts, really, what does successful treatment look like? It's abstract and saying stabilization. Most patients are going to have a new baseline with their LFTs, so please expect that. And then based on how they establish their new baseline, making sure they stay around there. You're not going to go back to what was before. That is long gone. If they've never achieved baseline after surgery, know that their baseline that they achieve if it's an early acute AMR isn't going to look great. And for a lot of these patients, you won't know what that true new baseline is for months. And so be patient, and when there's a level of stability that you think is the baseline, make sure they stay there. So that's very nebulous. And that's kind of the way that we have, based on, again, the not great data that we have that's out there. And so for me, like, I think if we look back at, the history of liver transplant, especially with the idea of immune tolerance and, in the era of the new implementation of, MELD for liver transplant, we thought we needed to save the kidney. We thought the kidney needed a life raft. And for us in liver transplant, we would delay the CNI. We would be very gentle about starting it. And if you do that, there is a very tangible impact that can happen, and in terms of increasing rejection risk, and in terms of putting that patient at risk for very damning immunologic consequences. For us as well, immunologically speaking, it's the healthier patients that you really have to look out for, especially the autoimmune etiology and our HCC exception patients, which we're seeing a lot more of now. And for us, even if you don't think it happens very often, if you're using a liver that's been on pump in a younger patient, and you're really like, why am I not seeing the results that I expect to see? Why isn't the liver numbers getting better? It could be IRI, but there's also a very real consequence of it might also be AMR. So keeping it on your radar to avoid any delay in diagnosis.
Okay. Whew. Well, I think we kind of, unfortunately set our patient up maybe for some early rejection by delaying their CNI. But Alicia, while I have you, I actually have another question, if I could. So we've got this heart transplant patient. So this is a 63-year-old African-American male who had a heart transplant about 9 months ago and presented to an outside ED with a syncopal episode. And his ECG demonstrated new onset ventricular tachycardia, and he was emergently transferred back to our center. Just so you know about him, heart failure secondary to dilated cardiomyopathy was maintained on an LVAD, and this was, if you can kind of think back before the allocation changes. So he was transplanted off an LVAD 2 years prior and had immediate graft function. His hospital stay was pretty uneventful, and he was discharged post-op day 16. Surveillance biopsies after the transplant and the most recent one a month ago just kind of showed some kind of mild persistent rejection. But when he transferred here, he required an intra-aortic balloon pump for support, and his biopsy revealed a mixed cellular 2R and antibody-mediated rejection with pretty nice donor-specific antibodies. So we immediately started him on some Thymo, gave him some IVIGs, some plasmapheresis, and some Velcade through kind of the first week of his course. But unfortunately, we know that those don't always work. So kind of moving on to the next slide, just as, kind of as a reminder, we're sort of tossing around all of these different agents potentially. So looking at some newer agents hitting anti-CD38, where there's some case reports, and then using the long-acting irreversible protease inhibitors, some eculizumab, maybe tocilizumab that we heard about in the very first talk. Is that something that we should put into place? And we've seen more of that data come out in the, the kidney transplant population, and then some of the newer agents. But what are your thoughts about these agents and their use in AMR for heart transplant? Should we consider this alternative? Should we consider eculizumab? You know, what should we do long-term if something works? I'm handing it over to you.
Yeah, I mean, I think in the setting of heart transplant, just to kind of go back to this slide, I really think that sticking, you know, and the risk actually kind of similar to liver transplant, the perceived risk of infection is also very palpable in heart transplant. You're also walking the very thin line of can we treat this without getting them sick? Most centers will, you know, still start with plasmapheresis IVIG. I know, you know, that's something that we did at the University of Cincinnati or University of San Diego, and then also where we would kind of start with in heart transplant. But I think a lot of centers are starting to reach, and I think it's very wise based on some of the initial data that's out there in heart, but also our friends from Kidney Land demonstrating that some of these longer term proteasome inhibitors could be of benefit. In heart transplant, there is some emerging data with tocilizumab, an IL-2 blocker. For us, we've used it in San Diego with the framing of study patients. And I've seen our children's hospital actually use it as like a chronic rejection modality agent. But what long-term IL-6 inhibition looks like in a data-rich way, we don't really have those studies, I think, out there that say like, yes, you should. If it's, you know, a very early rejection episode, I'll use an example where we had a patient where they were getting, the donor got massive blood transfusion, and we ended up transplanting. And based on those massive blood transfusions, the blood type of the donor was not actually the blood type we thought it was, which is a very long story for another day. And they had a very acute antibody-mediated rejection that necessitated eculizumab during the inpatient stay. So I think there are situations where you should and can reach for these, but I think they're far and few in between based on the bread and butter regimen of plasmapheresis, IVIG, and maybe plus or minus a proteasome inhibitor. Again, I think thinking about where did this rejection come from and why, and getting an early leg up on it is also a good preventative strategy, or a good initial thought to what would be the most aggressive steps to take, in my opinion. So for us, you know,
Okay.
Oh, go ahead.
Yeah. Go ahead.
Nicole.
Oh, no, keep on going. Tell me about the recommendations, because I have more to this case.
Okay. So although I moonlight in thoracic transplant, you know, I do know based on the 2023 guidelines, there are new recommendations for antibody-mediated rejection. And it's more commonly identified, if you really think about it, in the late acute rejection compared to acute cellular rejection. And that's mostly because, one, we can get a little bit lazy when it comes to maintenance immunosuppression. Two, the new CAR effect wears off for patients, and that can affect some of their compliance. It also, for us, we're trying to avoid some of the long-term complications. So entering and thinking about AMR and late AMR into the differential diagnosis is really critical. For us, using the different biopsies with immunopathologic evaluation, along with routine DSA monitoring, is actually something that your centers don't do. A lot of centers already kind of have that baked into their biopsy and monitoring of their chronic patients, is really important. Additionally, if you're going to start therapy, having those baseline things are pretty much paramount and critical, because they're going to help. What is your baseline? And then from there, based on what your treatment is, where do we go from here? Something that's new, you know, and I didn't think needed until 2023 to include in the guidelines, is really that careful assessment of adherence and co-medications or supplements. You know, what could be triggering events, And so for us, in any case of late rejection in the adult, in the pediatric, but looking at that non-adherence is really paramount in terms of once we treat it, what is something that can also continue to give longevity to the allograft and ameliorate this from recurring or happening again or malingering. So something to keep in mind. Again, I think especially pharmacists are looking at non-adherence, but having it be called into the recommendations with a pretty high recommendation level of a 2A evidence level B, shouldn't need stating, but is something that when we think about these late cases really should be front of mind. So for us, really thinking just rejection is key and prevention is key. An ounce of prevention, a pound of cure. So for us, ensuring baseline immunosuppression is intensified is really where I go first. And then considering, monitorable drugs, mTORs, CNIs, if they were on a belatacept-based regimen for renal sparing, get them off it. We need to actually know where they're at. And then non-adherence. So really, despite kind of negative or minimal rejection on biopsy, if a patient's not having adequate tacrolimus trough levels, or they're not filling their mycophenolate, reliably, intervening on those rejection, risk factors early is probably going to be your biggest thing. For us, something I thought was an astounding piece of information was over a quarter of heart transplant patients have major depressive disorder at 1 year post-heart transplant. And so for us, what we've done at San Diego is really integrate that depression screening into their visits when they've been with us, to kind of catch some of these other sociologic risk factors for non-adherence in our program as well. So with that, what do you think you've learned, Nicole? Like what in heart transplant?
Well, I was going to let you know, my intern was talking to my resident, Dr. Glaucoma Flecken, came back and along with my TGY2 resident, found out that this patient hadn't been filling their cell set for about 6 months.
Wow.
And actually, in talking to the wife, was really clinically depressed. And I think maybe we missed the boat with these early rejections. And instead of just looking at tacrolimus levels, maybe we should have looked at those early mild rejections as a surrogate for him being non-adherent, and we weren't looking at the right thing. So I think we needed to do a better job with probably, looking at this patient's history a bit more and looking for their fills. So yeah, I just got that in my ear when you were starting down this road. So I as you were talking about adherence, I'm like, oh, shoot, I mean, we missed that. So that's unfortunate. So yeah, big struggle. So, one last question is for the group, and I know that we're basically out of time, but I'd like to pose this to the group. And Alicia, feel free to chime in. So what if this exact same heart transplant patient who presented to this outside facility but it was a kidney transplant now. So they presented with antibody-mediated rejection, severe chronic rejection, they were hyperkalemic, required dialysis on admission. What would people treat with? And when would you throw in the towel?
I think there's any one way. There's no, if you polled all 5 centers that I've worked at for kidney transplant, people are going to approach this exact case 5 different ways. Maybe more, depending on what surgeon, what nephrologist is on service. For us, where I'm at now, and just kind of based on my transplant travels, I'm very much a plasmapheresis IVIG Velcade girl. If you can get that Velcade approved, if you can't, I think having longer session durations of IVIG plasmapheresis with bigger dose at the end is kind of a good place to start. If there is any T-cell mediated component, that's where I'm really adding on, very beefy steroid pulse and taper. For us, compared to liver transplant, I've seen this kidneys kind of respond a little bit quicker, albeit that response to rejection can still take months. So really it's, rebiopsying again about a month or so after therapy, seeing if they haven't reached a good nadir, like what is still salvageable, and having the rediscussion of, partial response, full response, or no response, what can we continue to do to maintain the mileage on that allograft before we need to repivoting. But if they haven't responded to plasmapheresis, IVIG, Velcade, and maybe like a rituximab, depending on their CD20 count, that's where I really start thinking about throwing in the towel, because any more than that, you could be really predisposing them to an infection where maybe just relisting and having them reinitiate, dialysis might be the preferred at that point, depending on, again, how they've responded to that initial bout of treatment. But I'm interested to see what other centers are doing, how other centers would handle this, how centers that have worked with in the past where, people are on, this call, like how they still do it or how they've changed. Curious to see what's out there. So what do you guys think?
Or even a show of hands, how would you keep on going in this patient forever, or would you relist after the initial therapy fails? Raise your hand if you would relist. Or if you're awake. Just kidding.
Saturday is pretty brutal. I feel this deep within my bones. I'm taking silences. We would keep going on until nephrology, determines like this baseline isn't sustainable. But with that, great back and forth. Thank you for calling me, Nicole. I don't get out of the water for just anyone, so I will certainly get out from off my surfboard for you. So, any questions from the group?
Thank you so much to our speakers. It looks like we do have a question for you. It looks like our question is for the livers. Is anyone routinely doing virtual cross-match prior to transplant?
No. We, at all of our centers, they were retrospective and really only like allocated to cases where the surgeon might have been concerned for IRI or in our TCD patients, which we would do quite a lot of them in San Diego. So about half of our patients got retrospective cross matches. And if there was a problem with someone that we might have not done a cross match on, we would do it down the line if we still had the blood.
Same with us.
Thank you for that answer. And it looks like we also have another question from Josh. He asks, you mentioned the role of checkpoint inhibitors increasing the risk of AMR in livers. I know we never know when patients will get transplanted, but ideally, is there a certain time frame prior to transplant that checkpoint inhibitors should be avoided?
We do not know the day or the hour. And so for us, San Diego had a really great case series. We really would try to have them wait 3 to 6 months to kind of get some of that out of their system. Even then, that's liver transplant. We know that's waiting like that sometimes is not feasible. So in our patients that have had, immune checkpoint inhibitors within 6 months, I believe they might have lowered it to 3 months. We actually did a thymo induction protocol, which thymo and liver always makes me very nervous, get a little colicky around it, but really, that's kind of the way that we've approached it, just based on some of the rejection that they saw doing, what was our standard induction at UCSD, which was no induction. So we would thymo them if they got recent checkpoint inhibitor therapy for induction, in the absence of maybe not being able to wait or not wanting to list them status 7 while they got that drug out of their system. I found those checkpoint inhibitor rejections to be very similar, again, just showing my age, to like the interferon-esque, rejections of the early HCV, era, where it's just they're very aggressive, and in that way, like starting with thymo induction and having like a very low threshold to be aggressive in monitoring is something that we did, and how we approached it. What did Wisconsin do, or how does Wisconsin navigate that?
Yeah,
Yeah.
no protocol. I think it's
Yeah.
a moving target. I do happen to know there will be a very nice board certification chapter coming out detailing how to handle these in 2025. So stay tuned for that. And publish your data.
Yeah.
Well, thank you again to our lovely speakers and to everyone who asked a question. We'll take another quick 5-minute break. So please be back at around 12:31 p.m. CST or 1:31 EST. Thank you. Okay, everyone, welcome back for our last and final session of today. Last but not certainly the least, we have discussions on immunosuppression considerations in special patient populations. We'll have two speakers again. So we'll have Dr. Megan Keck. Dr. Keck is Dr. Keck is a clinical pharmacist practitioner at Nebraska Medicine in Omaha, Nebraska. Her current clinical practice area is pediatric transplant, where she cares for patients in the inpatient and outpatient settings. She also serves as the PGY2 Solid Organ Transplant Residency Program Director and is a clinical associate professor at the University of Nebraska Medical Center College of Pharmacy. Following her, we'll have Dr. Mary Hebert. Dr. Hebert is a professor of pharmacy, adjunct professor of OBGYN, director of the University of Washington Obstetric Fetal Pharmacology Research Unit, core member of the University of Washington Center for Ecogenetics and Environmental Health, and member of the University of Washington Institute of Translational Health Sciences. She completed her PharmD residency and fellowship training at the University of California, San Francisco. Dr. Hebert joined the University of Washington faculty in 1996 and has a long-standing federally funded research program. Dr. Hebert has 37 years experience conducting clinical pharmacology research, starting her career in solid organ transplantation, studying pregnant and lactating individuals for 23 years, and resulting in an impressive 130 publications. Please join me in welcoming Dr. Keck and Dr. Hebert.
All right, thank you for joining today. I'm excited to talk to you about immunosuppression considerations in pediatrics. I have nothing to disclose, but I will be discussing off-label indications of medications during this presentation. So objectives of my presentation are going to be to evaluate immunosuppressive agents used for pediatric transplant recipients, highlight differences in pediatric patients that need to be considered when prescribing immunosuppressive agents, and discuss immunosuppressive regimens that have been used to optimize outcomes for pediatric transplant patients. When thinking about transplantation as a therapy for pediatric patients, it's important to recognize that there are significant differences between adults and children. These differences are not just age and size, but also include the cause of end-stage organ disease, physiology, immunology, and pharmacokinetics. Due to the smaller numbers of pediatric transplants, much of the data supporting current practice in pediatric transplant is based on expert opinion, extrapolating data from our adult transplant populations, or small case-controlled or cohort studies without randomization. What we do know is that pediatric patients will likely have a greater cumulative exposure of immunosuppression across their lifespan, which may pose a greater risk of adverse effects, post-transplant infections, and malignancies compared with adults. Other things that may potentially affect their long-term outcomes include challenges with medication administration in young patients and issues associated with non-adherence in adolescent and young adult populations. So the intent of my presentation is to highlight these considerations when managing immunosuppression for pediatric recipients. Key differences in pediatric pharmacokinetics exist for pediatric patients that should be considered when prescribing medications. Rates of drug absorption in infants are lower than absorption rates in children and adults. This is due to prolonged gastric transit time and variable gastric pH, leading to diminished absorption. At birth, gastric pH is neutral, but gradually increases to adult levels by age of 3. Other factors in infants that can decrease drug absorption are low levels of intestinal flora or reduced enzyme function, which are necessary for active transport of some of the drugs. Gastric emptying rates do become faster in children that help enhance the drug absorption at later in life. Infants have increased total body and extracellular water, which results in higher distribution rates compared to children and adults. And it accounts for 75% of their body mass in infants, but gradually reaches adult levels by the year of 2. Because of this, larger weight-based doses for hydrophilic drugs are needed to achieve similar plasma concentrations. The liver is a major site of drug metabolism, and infants have reduced hepatic metabolism. Changes in cytochrome P450 expression change from birth as children grow and reach adult levels by 1 year of age. So in children compared to adults, drugs are metabolized more quickly. So drug doses relative to body weight often need to be higher for children. And then lastly, kidneys are not fully mature until 12 months of age, when they are at a state where they can excrete drugs effectively from the and prevent drug accumulation and toxicity. All of these factors weigh into how we dose medications differently in pediatrics compared to adults. Other considerations that make drug dosing challenging for pediatric recipients, especially infants and young children, include drug formulations that are commercially available, route of administration, and the complexity of regimens that impact medication adherence. So most young pediatric patients require liquid formulations for administration of medications. While there are some of these commercially available, that's not the case for all medications. And so it's often necessary to either find pharmacies that are willing to compound the medications, or if you have an appropriate dose, utilize crushing tablets or opening capsules to administer them. But along with this comes the requirement that the patient is actually agreeable to swallowing said preparation. So, many medications may be unpalatable, and some children will simply refuse to take the medication due to either taste, oral aversions, or just being a strong-willed toddler. So the medical teams and parents often have to trial different methods to try and encourage medication administration. And if you can't find a successful one, may end up having to place enteral feeding tubes to allow for administration. So feeding tubes then may remove the barrier of taste, but come with it challenges associated with enteral tubes and potentially changes in drug absorption. So consistency and route of drug administration is essential to ensure that you have stable drug levels. Lastly, for adults, sublingual administration is often a good alternative in patients who are unable to take oral medications. But this can be especially challenging to try and give to uncooperative pediatric patients. And so it's not as feasible as it seems. And then lastly, with adherence, tools that we use in our adult populations like pill boxes or pill packs just aren't an option in patients who are on liquid medications. And so it's really critical to try and simplify these complex regimens where patients are receiving multiple liquid medications. While giving medications twice daily is ideal, this isn't always possible in pediatric patients who can't tolerate the volume of medications all at one time without having abdominal discomfort or emesis. And so other things, pharmacists, simple things that we can do to try and help facilitate these regimens are rounding doses to round numbers that are easily measured with oral syringes, adding medications to enteral formula if reasonable, and also ensuring that patients just have plenty of supplies like oral syringes at their disposal to administer medications. But the end game isn't just getting patients to being able to swallow pills, because adolescents pose a whole new challenge when it comes to taking medications and being adherent with them. Non-adherence for adolescents poses a critical threat to their long-term graft outcomes. And so education and awareness of all involved in their care is necessary to be able to identify it early and try and identify strategies to combat it. We can utilize the SRTR data to examine current immunosuppressive agents utilized in pediatric transplant recipients in the United States. So due to the time constraints of this presentation, I'm going to focus just on the most common ones, being kidney, liver, and heart. Selection of which induction agents are used, similar to adults, is dependent on many factors, including sensitization at the time of transplant, plan for maintenance immunosuppression after transplant, and then the risk of infections or recurrent disease. The green lines on these graphs represent when induction therapies were actually used, and the blue lines were that no induction agent was used. So starting with pediatric kidney transplant recipients, almost all of the patients, greater than 90%, reported used an induction agent in 2022. This is fairly consistent over the past decade and very similar to adult transplant recipients. Only about 40% of pediatric liver transplant recipients receive an induction therapy agent. And lastly, over the past decade, we've seen a slight increase in heart transplant recipients using induction agents, with 84% of pediatric heart transplant recipients receiving induction therapy in 2022. The widespread use of induction therapy in heart and kidney transplant recipients in pediatrics has less extensive data to support its use compared to its adult counterparts. So in pediatric kidney transplant recipients, the benefit of basiliximab to prevent rejection compared with steroids alone has not been consistently demonstrated in the literature. We don't have any randomized controlled trials comparing alemtuzumab with antithymocyte globulin or basiliximab in peds, and so its role is also unclear. However, we do believe that patients who are sensitized or deemed higher immunologic risk likely benefit from induction therapy, as do patients who plan to use steroid minimization or withdrawal immunosuppression regimens. The utilization of induction in immunosuppression and liver transplant is not widespread, as we saw from the previous slide. But it has also been reported to allow for minimization or delay of initiation of calcineurin inhibitors or decrease the dependence of steroid use. So a recent study published by Dong and colleagues this year investigated the use of basiliximab and tacrolimus monotherapy compared to traditional regimen of tacrolimus and steroids in 150 pediatric liver transplant recipients. The study demonstrated that the use of basiliximab induction therapy could reduce the incidence and delay the onset of acute rejection episodes. We do know that patients who receive the more potent induction therapy are at higher risk for adverse effects with bone marrow suppression, infections, and PTLD. So this must be balanced with the potential benefits of less rejection and long-term patient outcomes. Turning to maintenance immunosuppression, the most common maintenance immunosuppression regimen at hospital discharge for pediatric kidney transplant recipients has consistently been tacrolimus, mycophenolate, and steroids, with 54% of the recipients in 2022 on this regimen. In 2022, 78% of pediatric liver transplant recipients received a steroid-containing initial immunosuppressive regimen, with the most common being tacrolimus, mycophenolate, and steroids, or tacrolimus and steroids alone. And in 2022, we see for the first time, the initial immunosuppressive regimen for used most commonly in pediatric heart transplant recipients was tacrolimus and mycophenolate at 46%, closely followed by tacrolimus, mycophenolate, and steroids at 43%. So let's talk about these various agents used and provide some clinical pearls that may explain why we're seeing these trends. So tacrolimus was obviously the calcineurin inhibitor of choice, likely due to its benefit of reducing graft rejection. In patients intolerant of tacrolimus, cyclosporin is still a reasonable alternative. And while immediate release formulations of tacrolimus are used most commonly, there is an increased interest in using the LCP tacrolimus once daily formulation, especially for adolescents to enhance adherence. This past year, Keck et al. Published a phase 1 study evaluating the pharmacokinetics of LCP tacrolimus or Envarsus in pediatric kidney transplant recipients compared to twice daily tacrolimus. In 5 adolescent patients, ages 11 to 17, it confirmed the extended release PK profile of LCP TAC, which was delayed time to maximum concentration, lower maximum concentration, but comparable to tacrolimus AUC. So although limited data, it does provide us some comfort when converting patients from twice daily to once daily formulations. Other clinical considerations that transplant pharmacists should be aware of are that younger children may need higher weight-based doses or more frequent dosing of tacrolimus due to higher drug clearance than older children, adolescents, or adults. Another common strategy is to transition patients to 3 times a day dosing if necessary when you're unable to achieve adequate drug concentrations, giving the medication twice daily. It's also been observed that tacrolimus compounded suspension has reduced absorption. So if unable to achieve therapeutic concentrations with suspension, we will consider switching to capsules. Similar to adults, the concern of long-term adverse effects, such as chronic kidney disease and cardiovascular disease, is a primary focus of pediatric immunosuppressive management as a way to improve overall graft survival. A study done by Jissing and colleagues reported the prevalence of chronic kidney disease in non-renal transplant recipients up to 70%. And so looking at other combinations of induction agents or other maintenance immunosuppression is being studied to see if there are alternatives available. As we know from the SRTR data, steroids are commonly still prescribed as maintenance immunosuppression, but we're all well aware of the downside of steroids. So we know pediatric patients are especially prone to bone disease, growth impairment, and cardiovascular complications with that. So when we are looking at some of those alternative studies, as well as with calcineurin minimization, we see places trying to use steroid minimization and steroid withdrawal as a way to impact patient outcomes, as we know that patients who are on these protocols often have lower blood pressure, lower cholesterol levels, and better linear growth. So a couple of studies that have demonstrated this, one by Sampleris published a meta-analysis in 2017 examining the effect of corticosteroid withdrawal or avoidance on growth and safety parameters in pediatric kidney and liver transplant recipients. So they included 14 studies that included a total of 1,146 patients. The studies included mixed approaches to steroid minimization, including avoidance, where no steroids were given, and then steroid withdrawal at varying times post-transplant. The study observed significant improvement of growth in the pediatric kidney studies. As expected, this effect was more pronounced in younger patients. And while the same result wasn't seen in our liver population, the authors did note that there was a smaller sample size of those patients, and at baseline, they were on lower doses of steroids to begin with. A study assessing the medium-term outcomes of steroid avoidance protocol in pediatric heart transplant recipients was just published this year by Hart Dunn and colleagues. They included non-sensitized and sensitized patients who had a negative cross-match at the time of transplant. The patients received antithymocyte globulin with steroid pre-medications, but then no maintenance steroids were started with tacrolimus and mycophenolate. The primary outcomes assessed were graft survival and acute rejection. The median length of follow-up was 6 years after transplant. 143 of the 150 patients included in the study survived until discharge. 13% of the patients were on steroids 1 year post-transplant, and the overall 1-year graft survival was 94%, and 5-year graft survival was 87%, which was similar to previous reports from the ISHLT registry. Overall, 38% of patients were diagnosed with acute rejection during the study period, which was also comparable. Clinical considerations for use of antiproliferatives in pediatric patients that should be considered are that mycophenolate is probably our most common agent that is used, but azathioprine does still have a role for patients who perhaps can't tolerate mycophenolate. So in our adult patients, a common practice for patients who are having difficulty with GI side effects associated with mycophenolate mofetil is to switch them over to mycophenolate sodium. However, this is not an option for pediatric patients who are unable to swallow pills. So more commonly employed strategies amongst pediatric patients includes giving the dose, smaller doses more frequently, such as TID dosing, or giving it with food, or just simply having to change to azathioprine if this doesn't resolve the issue. Another challenge in pediatric transplant is timely addressing birth control when adolescents become sexually active. So emphasizing the importance of appropriate birth control methods is critical, but this can be difficult to discuss depending on the parent-child dynamics when you're seeing these patients. And so risk versus benefit must be considered. And if patients are deemed unreliable or you suspect they're could involve in risky behaviors, then perhaps conversion to azathioprine would be appropriate. Similar to adults, mTOR inhibitors are avoided early post-transplant in our pediatric patients, but they're often the go-to agents when we need to limit calcineurin inhibitors, if we're employing steroid minimization protocols, and also considered in patients who have a history of malignancy, such as hepatoblastoma, or used for chronic allograft rejection. One of the pharmacokinetic differences we see is with sirolimus, in that it has a shorter half-life in pediatric patients. So twice daily dosing may be required to achieve therapeutic levels. And similar to adult patients, when we look at the studies involving mTOR inhibitors in our pediatric patients, there are still high discontinuation rates due to tolerability issues. So this has to be factored into development of protocols with mTOR inhibitors. And then belatacept, one of the newest immunosuppressants we have on the market, is not FDA approved for pediatrics, although we do have some limited evidence of use in adolescents. So the potential benefits that we heard about earlier in Dr. Byrns' presentation of improved renal function is one of the things that interests us, as well as perhaps improved adherence that makes it which would make it a good alternative for, again, some of our pediatric patients with that issue. Of course, applying it to the standard transplant game of risk versus benefit, we do have limited data involved in safety of this agent in this population, as well as our concern about the risk of PTLD, as pediatric patients are more likely to be EBV negative compared to adults. So a variety of patient populations with mixed immunosuppression regimens have been reported in the literature, although small case control studies. Lurch et al. Publish on their experience in converting non-adherent adolescent kidney transplant recipients. The 6 patients they included were between the ages of 15 to 17 years old, and their median time post-transplant was 7.5 months. 3 of the patients were started early after transplant within 3 months, and all of them but one were on mTOR inhibitor-based therapy, with half of them also on steroids. After conversion to belatacept, 3 of the patients had improved renal function, and 3 of the patients saw the decline in their renal function stabilize. For the duration of the study, 1 patient experienced an acute rejection episode. But of note, what the authors were looking for was there was 100% adherence to their outpatient appointments. And so this speaks to potentially the benefit of adherence. Blue et al. Described de novo use of belatacept in 3 adolescent kidney transplant patients who were all given alemtuzumab and steroid induction. And then 2 of the patients were initiated on sirolimus and 1 was on belimumab. Allograft survival was 100% for the 20 months of follow-up, and 1 patient was reported to have acute rejection that was treated with steroids. And then most recently, Garo et al. Reported on their use of belatacept in 10 pediatric kidney transplant recipients who were converted over from the traditional immunosuppression regimen of basiliximab, calcineurin inhibitor, antimetabolite, and steroids to belatacept. The calcineurin inhibitor was able to be discontinued in 70% of the patients, and there were no episodes of rejection observed. The patient's GFR remained stable or improved over the course of follow-up. So clearly we need more data on how to safely use belatacept in our pediatric population, but these initial reports show that there may be a role for it in targeted populations. In conclusion, induction therapy is commonly used in pediatric kidney and heart transplant recipients. The most common maintenance immunosuppression regimens we see used in pediatric recipients are tacrolimus, mycophenolate, and steroids. And strategies to minimize long-term toxicities in pediatric transplant recipients continue to be studied.
I'd like to thank the organizers for this session for including me in this discussion, and I'm happy to talk about pregnancy following solid organ transplantation. At the end of this talk, you should know and be able to apply which immunosuppressives should not be used in pregnancy, know and apply when immunosuppressives should be discontinued prior to pregnancy if they're not supposed to be used during pregnancy, and be able to apply your understanding of pharmacokinetics changes in pregnancy and the management of pregnant transplant recipients. I don't have any conflicts of interest. So pregnancy following transplant is a very complicated pretzel. I think all of us know that transplant recipients and their care is complicated, but then when we add in pregnancy, it's even more so. So we, in addition to our usual transplant complications and the underlying conditions and adverse effects of the drugs that we're used to giving, we also have the pregnancy complications that are at much higher frequency in following transplantation than in the non-transplant recipients. For the fetus, we're thinking about malformations, growth and development, and adverse effects. And then in the offspring, the adverse effects associated with in utero exposures. If you're not very familiar with pregnancy, it is one massive drug interaction. There's changes in drug metabolism, renal filtration, drug transport, and protein binding, all of which make it very difficult in the management of patients receiving the immunosuppressives that we use all the time. These patients are complicated to the extent that they are considered high-risk pregnancies and should be followed ideally by a maternal fetal medicine specialist or at least an obstetrician that has experience with transplant recipients as well as the transplant team. So there are multiple organizations that have made recommendations regarding pregnancy after transplant. These are some of the highlights. So pregnancy should be deferred at least a year following transplantation in most transplant recipients, but 2 years for the lung transplant recipients. If patients get pregnant in that first year, it increases the risk of graft dysfunction, rejection, graft loss, and premature birth. Ideally, we'd like to have stable allograft function and control of the chronic conditions with hopefully a serum creatinine less than 1.5 and minimal proteinuria and no rejection in the last year. We also are looking for no acute infections because it can impact fetal growth as well as well-being, and then stable maintenance immunosuppression and stable dosing. Hopefully, as you get out farther from transplant, we're able to accomplish this in almost all our patients. Some things you might not be familiar with is that patients that, because the transplant recipients are much higher risk for preeclampsia, they are given aspirin for preeclampsia prevention. It's recommended to monitor drug concentrations, which we, of course, would think to do that anyway, but interpreting the drug concentrations are much more challenging in a pregnant patient. And then maintaining current immunosuppression, with the exception of the mycophenolic acid products, because these are major teratogens and should not be given during pregnancy. So patients are recommended to use highly effective contraception if they're getting mycophenolate mofetil or sodium mycophenolate or any other teratogens. And then the target delivery is at term 37 to 39 in 6 days, with a preference towards the latter part of that. There's actually data that shows less good outcomes in babies born at 37 weeks versus 39 plus. The good news is that even though we're watching and monitoring and taking care of our patients in ways that many of us are used to, 70 to 75% of the pregnancies will result in live births following solid organ transplantation. But we do monitor for rejection. It's a relatively low incidence. 2.39% is the pooled incidence for rejection. Graft loss during pregnancy is low, 1.55%. And then graft loss within 2 years does go up quite a bit, 4 to 14% in the kidney recipients and 3 to 9 in the liver recipients. Gestational diabetes, not uncommon, 8% in the kidney recipients and 5% approximately in the liver recipients. Infections are common at 14%. Hypertension is super common. We see it all the time in our transplant recipients, even when they're not pregnant, but 54% of the kidney recipients and 27% of the liver recipients will have hypertension in pregnancy. The thing that we worry a lot about is preeclampsia, and the rates of preeclampsia are quite high in this population, 27% in the kidney recipients and almost 22% in the liver recipients, which is almost 6-fold higher than a non-transplant recipient. Preterm birth prior to 37 weeks gestation is also fairly common, almost 46% in the kidney recipients and 39% in the livers, over 6-fold higher than the non-transplant recipient. And low birth weight infants, again, over 6-fold higher in the transplant recipients than non-transplant patients. These patients, as I said, are a complicated pretzel. The conditions that we're used to managing all the time in the transplant recipients increase the risk for pregnancy complications. So diabetes and hypertension increase the risk of preeclampsia. Hypertension, diabetes, and infections increase the risk of preterm birth. Malformations are increased frequency in patients that have high sugars in the first trimester, and then those that get some viral infections. Gestational diabetes, so pregnancy is even normal pregnancy is associated with insulin resistance. So if our patients are on the border of glucose intolerance, they are more likely to develop gestational diabetes. and patients that have diabetes coming into pregnancy are at increased risk for their glucoses getting out of control. And then low birth weight infants, increased risk with hypertension and a variety of infections. So we're used to managing all these complications, but they all are confounded when the patient is pregnant and increase the risk of pregnancy complications. The other thing that's really tough to sort out is the safety of individual medications. The reason for that is, if you give a single drug and you have an adverse pregnancy outcome or malformation with that exposure, it's very easy to say whether the drug is causing it or not causing it. But the patients that are getting immunosuppressives have multiple medications at the same time. And on top of that, they have concomitant illnesses, all of which confound the interpretation of the safety data. Nonetheless, I'm going to talk about the common immunosuppressives. Let's start with tacrolimus or tacrolimus, depending on which institution you're at. Maternal complications that are higher in patients receiving tacrolimus include hypertension, preeclampsia, and preterm delivery for the mother. And then we have the usual suspects of what can happen in terms of just straight out adverse effects that we're used to dealing with this drug. For the fetus, it's exposed to approximately 50% of the maternal concentration. But even though the drug is crossing, the birth defect rate with tacrolimus is 4.2%, which is comparable to the US population, which is 3 to 5%. There's also no consistent pattern of congenital defects, so it really isn't thought to increase the risk of malformation. There is fetal growth restriction, meaning small babies. There are some concerning case reports of cardiomyopathy, congestive heart failure, and anuria in the fetus, but not enough data to tell us if this is tacrolimus related. And then in the offspring, so after birth, we're looking at hyperkalemia, elevated serum creatinine, and low birth weight. So as I mentioned, one of the recommendations is that we monitor our drug concentrations when patients are pregnant. There's multiple reports of different investigators reporting lower drug concentrations during pregnancy, increase of parenteral clearance, an increased need for higher doses across different studies. We took this one step further, and on the figure on the right, you can see our data where we looked at dose normalized tacrolimus concentrations during pregnancy. So we've got early, mid, and late pregnancy compared to 3 months postpartum as the control, and the concentrations fall. In response to that, of course, the providers were quite good, increasing the dose, going along with that, and were able to keep concentrations in the target range quite well. But because we measure whole blood trough concentrations clinically, unfortunately, this keeping the target concentrations in our usual therapeutic range resulted in increases in unbound tacrolimus concentrations and the associated nephrotoxicity and neurotoxicity that goes along with it. So it's very difficult to interpret tacrolimus concentrations during pregnancy because we have lower albumin concentrations, lower alpha-1 acid glycoprotein concentrations, and lower red cell counts during pregnancy, which increase the fraction unbound. We also have an increase in 3A and P-glycoprotein activity. So creates a challenging situation, but in understanding the pharmacokinetics, at least you're going to understand what's going on. Cyclosporin is quite similar in both its toxicity profile and what we're seeing in changes in pharmacokinetics. We see increases in preterm delivery, increases in preeclampsia, the usual cyclosporin adverse effects. on the maternal side. For the fetus is exposed to 30 to 64%, depending on which report you're looking at, of the maternal concentration. And like tacrolimus, which was around 50%, these drugs are effluxed away from the fetus by P-glycoprotein, which is expressed on the placenta. So the concentrations tend to be lower than the maternal concentration. And the fetus there are reports of fetal growth restriction and stillbirth. For the offspring, low birth weight infants, renal dysfunction following in utero exposure, but it resolves when it was looked at 3 and 7 years, there were no differences. And then there are case reports of some things that are more concerning following in utero exposure. But there's no effect on physical growth or gross motor development at 2.5 years, and no significant difference in neurocognitive performance, which of course is somewhat relieving. Okay, so when we're looking at cyclosporin, again, we've got different studies that have previously reported changes or no changes in trough concentrations and need for changes in dosing. The data is conflicting, likely because of different assays that were used and different transplant populations that were reported on. These are very small, but you can see in the graph on the right that trough concentrations generally fall during pregnancy, with the corresponding providers increasing the dosing, which are the bars. So the line is the trough concentration and the bars are the dose. However, cyclosporin has not been studied in terms of its protein binding changes during pregnancy. It is likely to have a similar change to what we see with tacrolimus, with an increase in fraction unbound, but it has not been studied. But it does have very similar pharmacokinetics to tacrolimus. The corticosteroids, depends on which corticosteroids you're talking about. Of course, if you're looking at betamethasone or dexamethasone, which are fairly commonly used for enhancing fetal lung maturity because they do cross the placenta, this is contrasted with our usual corticosteroids, prednisone and methylprednisolone, that are metabolized by 11-beta-hydroxysteroid dehydrogenase in the placenta. And so we end up with lower fraction crossing to the fetus. When we're looking at maternal complications in patients that have received prednisone or prednisolone during pregnancy, there's higher rates of preeclampsia, preterm birth, especially with higher doses, and then premature rupture of membranes, and even perinatal death has been reported. Of course, the usual adverse effects that we see in our transplant patients, plus that we need to consider the poor wound healing if the patient requires a surgical delivery. For the fetus, as I mentioned, we have lower concentrations on the fetus. It's like approximately 10% of maternal concentration. There are reports of fetal growth impairment. There's conflicting data about risk for cleft lip with or without cleft palate. The data is conflicting. Overall, it's unlikely to pose a substantial teratogenic risk. And then for the offspring, we do have low birth weight infants, possibly an increase in stillbirth and neonatal adrenal insufficiency, especially with higher doses. And then a variety of case reports of adverse effects that may or may not be related to the prednisone and prednisolone. There's no difference, however, in bone mineral density, growth, or other indicators of health. The changes in the kinetics for prednisone and prednisolone are kind of interesting, whereas for almost all drugs, those bound to albumin or alpha-1 acid glycoprotein, we expect to have higher fraction unbound during pregnancy. Prednisone and prednisolone are bound to albumin, but they're also bound to corticosteroid binding globulin and actually have higher binding or a lower fraction unbound for prednisone on the left and prednisolone on the right. The blue represents the pregnancy and the red representing the postpartum control. The good news is when we look at the pharmacokinetics of prednisone and prednisolone, there's no change in unbound prednisolone apparent oral clearance during pregnancy, and so no need to change the dose. Okay, when we get to mycophenolate mofetil and sodium mycophenolate, we have a bigger problem. And instead of getting into, I've included the pregnancy complications and other points of interest on this slide, but what's the reality is these drugs should not be used in pregnancy. They have a ballpark 25% risk of major malformations and really shouldn't be used in pregnancy. They affect the ears, the cleft, ocular, visceral, fingers, toes, trachea, esophagus. We've seen diaphragmatic hernias. If you do the training on MMF in pregnancy, it actually has that listed and says it doesn't cause it, but we've seen it, a massive diaphragmatic hernia in a patient that got MMF. And then corpus callosum, renal, vertebral, neural tube, and heart all are at risk for malformations with these drugs and should not be given during pregnancy. It is recommended by the FDA to discontinue 6 weeks prior to pregnancy. And you might be thinking, oh, that's a long time, the half-life of the drug, that, you know, but the issue isn't so much in terms of the birth outcome between less than 6 weeks or more than 6 weeks. There's not a difference in the birth outcomes. Where the difference has been reported is in the long-term graft loss, with a higher rate of 5-year graft loss if mycophenolate was discontinued less than 6 weeks prior to pregnancy. And as I've previously mentioned, it is part of the REMS program. Okay, azathioprine might sound like a very scary drug in pregnancy. It is an anti-metabolite, but although azathioprine crosses the placenta, it's not converted to the teratogenic 6-mercaptopurine by the fetus, and the there is fetal growth restriction, but when we look at overall malformations, it's about 4%, which again is basically the same as the US population of 3 to 5%. There's also no pattern to the malformations, so it doesn't look like it increases the risk of malformations. There is higher risk of low birth weight infants and small for gestational age infants. And from a mechanistic perspective, we certainly can understand how come there's reports of lymphopenia, leukopenia, pancytopenia, and anemia in the offspring. There's also reports of childhood infections requiring hospitalization and even transient acquired chromosomal breaks and rearrangements. 2021 publication reported that the fetus is exposed to an active thiopurine metabolite, 6-thioguanine triphosphate, but it still is a 4% incidence of malformation, so I'm not sure that this is critically important. Okay, now we're going to move to the mTOR inhibitors, sirolimus. There's pretty limited data. I was able to find reports that look like 55 cases. Sometimes it's a little hard to tell because you don't know if somebody's reporting repeatedly other cases, but I think we're looking at right around 55 cases. Live birth rate, 74%, consistent with other immunosuppressives. Preterm delivery has been reported. And in a small case series, there was about a 50% incidence of miscarriage. Whether that holds to be the case is still to be determined. And then, of course, we would be concerned about delayed wound healing following surgical delivery. It is recommended to discontinue sirolimus 12 weeks before pregnancy, not because of the half-life. It's got a relatively short half-life, but Again, I believe that this is related to stabilization of the immunosuppression prior to the individual getting pregnant. There are reports of fetal growth restriction, case reports of normal development after early pregnancies exposures. There are concerns about these drugs because the mTOR is involved in embryogenesis, but based on what we know, it doesn't appear to be a major teratogen, and the malformations that have been reported, there doesn't appear to be a pattern. The risk in terms of the offspring is still unknown, but we do know low birth weight infants have been reported. Like the calcineurin inhibitors, sirolimus is a substrate for 3A and PGP, and also bound to albumin, alpha-1 acid glycoprotein, and the red blood cell. So you'd expect similar PK changes in pregnancy. Everolimus, there's even less data, only N of 8. But normal outcomes have been reported, a live birth rate of 71%, consistent with the other immunosuppressives. It does cross the placenta with umbilical cord concentrations of about 0.6. The teratogenic risk really is unknown. We don't have enough data to really say. There are reports of intrauterine growth restriction, and we do, like with sirolimus, have concerns about the role of mTOR in embryogenesis, but of the limited human reports that have been out there, all of them were without malformations. Similar to the calcineurin inhibitors, we got the same pharmacokinetic issues we're concerned about. Belatacept, and I heard somebody at a recent meeting pronounce it belatacept, so I guess that depends on which center you're at too. There's only a small number of reports, 25 is what I found. There's reports of miscarriage, preeclampsia, preterm birth, in 8 pregnancies and 5 solid organ transplant recipients, resulted in 4 live births. Of those 4, there were no birth defects and no developmental concerns out to 5 years. There are normal human development pregnancies that have been reported, but too few to really tell us about the safety, and there hasn't been any pharmacokinetics in pregnancy. Thymoglobulin, there are no controlled data in human pregnancy. There's just not enough data. There are reports of intrauterine growth restriction, preterm birth. Some case reports of no adverse hematologic or infection-related issues. No reports of malformations. Intrauterine growth restriction, however, has been reported, and long-term effects on the immune system are really not known. No pharmacokinetics available in pregnancy. Rituximab is a little bit more concerning. It does cross the placenta via the FC portion of rituximab, and the fetal exposure is 30 to 120%. We do know that it can, the preterm delivery rate's 22%. We're only looking at a relatively small number of exposures, but there have been plenty that have had live births, some stillbirths, miscarriages, and the big concern for anybody who's taking care of a patient receiving rituximab during pregnancy is its impact on the B cells, with complete depletion of B cells, immature B cells, neutropenia, hypogammaglobulinemia, and B cell defects in the offspring. We've seen this. There have also been patients that have been exposed 6 to 12 months prior to conception, even though the recommendation is to use contraception for at least 12 months. But in the 6 to 12 month window, healthy infants being born. Basiliximab, I couldn't find any human data. It isn't expected to increase the risk of malformation based on animal data, but we really don't know without any data. Thank you very much for your attention, and I'd be happy to take questions along with Megan. Feel free to unmute yourself if you do have a question, or type it in the chat. We're happy to take them. I know it's been a long morning.
Thank you both very, very much. Sorry, camera's off. I'm just curious if you have any experience treating rejection in pregnant recipients.
Oh, absolutely. It's not real common, but sometimes they are not able to keep up on keeping the concentrations in the target range, or they've had their immunosuppression changed recently, just before pregnancy. And so, yes, that and as you would expect, if you are using corticosteroids, you're going to see hyperglycemia issues, even more so than when you're treating the same patient when they're not pregnant. Pregnancy is associated with quite intense insulin resistance. And so the corticosteroids, that's the big issue. That also, of course, hypertension. And then thymoglobulin, I've seen it used. It seems to be a little bit better of a choice than rituximab. And I have seen rituximab used during pregnancy and led to totally obliterated the bone marrow in the newborn. So yes, I haven't seen alemtuzumab used during pregnancy. There may be others who have seen that, but
Thank you. That's helpful. I, hope to never be in that situation, but I figured while we have friends on the line that, similar to Alicia and Nicole Stock, can answer the question. I've kind of wondered myself, what would happen if we had to use thymo in pregnancy with the lack of data. So always helpful to have that perspective. I don't see any other questions in the chat at this time. Give anyone a moment to speak up if you have a question on this last session, or I think some of the speakers might be on if there was one that you didn't ask before. All right. Looks like a thank you to all of the presenters, which is exactly where I was going to lead. I know Saturdays are busy for everyone, especially as we approach the holiday season. So we certainly appreciate your willingness to present to us all today. In terms of CE information that will come out in the next 10-15 minutes or so, but please be mindful that the session codes are for each session, so you will need to complete the link for all 4 sessions to get the full credit for today. If you have any questions, my email will be included, so you can reach out. But thank you to everyone again for participating today and also for presenting, and I hope you have a great rest of your Saturdays.
thank you. Bye, everybody.
Take care.